Hello. 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 Hello.
Hi, Kshitij, all set to go?
Yes, sir. We are live.
We are live already.
Yeah, I have to share the link with Menon to give that a minute for me.
All the first 6 minutes have been, the first two sessions are fully recorded. They are with you, na? We are just playing the recorded session, right?
Yeah, so Abhishek has it. My computer kind of stopped working, so it's going to take me some time to transfer that. I'm using my wife's computer. So
Okay. Abhishek, are you here?
Yes, sir, I'm here, sir.
Abhishek, try your recording in the meantime in the background.
Yeah, I'll just do that.
So remember when you are sharing, when you are sharing,
yeah,
you have to. Yes, sir, we are live. You have to click on share computer audio. So when you share screen, there is a checkbox at the bottom.
Okay.
When you're playing the video, otherwise the audio of the video will not be heard.
Okay. My videos are playing. You want me to try, check and see if
Share it, yeah.
Okay.
My friend, and then we'll go ahead with this my presentation for 1 hour, and 1 hour would be presentation by Dr. John. And is that Sampath joining?
I have requested Sampath sir that he said that he'll just freshen up and try and join with us. So I think that
right. Okay.
It's playing, Kshitij, no?
Quick start.
Yeah, and a quick start. So I think John, thank you very much for giving us time today.
Kshitij, can you hear?
Yeah, I can hear.
Even the video ka audio?
Yeah.
Okay. So I'll minimize and keep it ready.
Yeah.
So Abhishek, is John joining us live or no?
No, sir. He said that his timing is too odd. He is not joining at present.
What about Judith?
Judith also not, because yesterday was some religious thing for them yesterday, like Saturday night over there.
Okay. All right. So what is the plan? The plan is that you will play this session which is first session for 2 hours. Is it full 2 hours?
My first session is for 2 hours, trauma. And
suppose people have questions, and then what will happen?
we will stop. Rajiv sir, I am there. Sampath sir is there. So we will take questions whenever there is a question in the chat box or wherever. Kshitij, where will the questions come?
On YouTube.
So how will we? I'll have to check it on the phone and keep
I'll
on.
send a link for the YouTube.
Okay, great.
Doing that right now.
Okay, perfect.
So you keep on checking, and then you can, and then of course, if people have questions, but at the end of the session, is the session recorded session exactly 2 hours?
Exactly 1 hour, 59 minutes, 14 seconds.
Okay, so that's almost. So then you won't have any time at the end to discuss anything.
No, I think the last session is of a shorter duration. So we have kept it in such a way that we can finish it at exactly 1 o'clock.
Okay. In between session 2 and session 3, there'll be a 5-minute message by the VIROC organizers,
Sure, sir. Sure.
which they'll want to come.
Sure.
We should have a time of about 10 minutes in between sessions to answer any questions or anything thoughts that any of the panelists wants on after each session.
Sure.
Okay.
Yes, sir.
I think Kshitij will go live at 9 o'clock. It's only 2 minutes left now.
Yeah.
Good morning, everybody.
Hi, Rajiv Bhai. Welcome. Thank you for joining us.
Good morning, sir.
Thank you for giving
The
time.
plan for the session today is that I will give an introduction to Bombay Orthopedic Society and then welcome the two conveners, and then you all take over. Each session, the first session will be, of course, you all will run it. But at the end of the session, I was just telling Abhishek that we should have a 10-minute question answer session where all the questions which come on YouTube and all the questions that you as panelists have, which you feel the audience will benefit from, you should put those questions to the panelists, each other, and get those solutions done. Then the second session, similarly, at the end, 10 minutes. Then 5 minutes, we need a break because we need to have the VIROC announcements made. And then we'll go to the last session of the day.
Okay, right.
Kshitij, did Pradeep get in touch? Because the last session is with him.
Hold on. I'm finding it. I'm running into some issues.
Okay, no problem. Or I'll call him up and I'll ask him to log in live and share the screen. No problem.
Pradeep has called me up last night. He has recorded his session for only half an hour.
Okay.
The remaining half an hour they could not record because of some delays in the starting off. So he said that 3 cases, the Jean Briholt has been involved in, and in the other 3 cases they will just present, and the panelists including Dr. Rajiv Shah, Malar Dave and Pradeep himself will answer the questions in that area.
So yesterday he called me up and then I said that I'll be little held up with Asia Pacific Foot and Ankle course, which is on the same day. It's starting by 10 a.m. and I have a talk there by 11:30. So hopefully before that I'll be finished with the first session, which we already recorded.
Okay.
So once you do the introduction of Bombay Orthopedic Society and the conveners, we'll start with the recording, which has an introduction of John Con also.
Okay.
Right.
Kshitij, you want me to stop share screen so that when sir gives introduction?
Share.
Yeah.
Sorted? Kshitij?
Just a minute.
Whenever you are ready, just tell me.
Also.
Okay.
Kshitij, you want me to stop share screen so that when sir gives introduction?
Share.
Morning, sir.
Morning, Agnivesh. Just waiting for Kshitij to set up things and then we can start rolling.
Can some Agnivesh,
Sir,
I have sent you a link. Can you copy paste that link into that BOS web app, apna BOS web WhatsApp group? I just sent you a web a link. What's YouTube
on WhatsApp? On WhatsApp,
Zoom,
sir?
on Zoom. I sent you on Zoom. Check your Zoom.
Yeah, I got it.
Please,
so I'll copy paste it
that
in the
my WhatsApp.
group.
Also, for some reason, it's giving trouble. And if you could check that link, if that YouTube is streaming, because it's streaming at my end.
I'll just cross check, sir. I'll just cross check.
And if you could check that link, if that YouTube is streaming, because it.
Yeah, it's on, sir. It's streaming.
So can you send that to Menon right now?
I'll just put it on the group.
Yeah.
Yeah. I pasted on the group. You want me to send somebody?
Yeah. So just. All right. So, Agnivesh, can you check on like a different device, not the same device, on your phone, this link?
I'll check it on my mobile. So.
Yeah. Something wrong with at my end. I don't want to spoil the live stream.
No, it's streaming, sir.
It's streaming, right?
Yeah.
All right. Perfect. So, I mean, the moment Menon gives us a go ahead, we can start. Hey, Rajesh, did you get the link?
Yeah, that link is not working. It says
no. Second one. Agnivesh sent.
No.
Second one also not working.
No, I haven't got the second one.
Second one is on the WhatsApp group. Agnivesh has sent.
Even Dr. Swapnil Kini has written that it's working on his phone.
Can you use that link?
Yeah, it is working on my phone too.
Okay. Rajesh, did you get the link?
Yeah, that link is not working. It says
No. Second one. Agnivesh sent.
I don't think he is on the. Is he there on the Master Series?
I haven't got the second one. Second one is on the WhatsApp group. Agnivesh has sent.
No, Rajesh is not on the group, Kshitij. You'll have.
Even Dr. Swapnil Kini has written that it's working on his phone.
Can you use that link?
I have just sent you on my phone. Rajesh, I have sent you a link on your mobile phone. Please check that.
So,
I don't think he's on the. Is he there on the Master Series?
He's there on WhatsApp on the web. It's okay. He's got the link. So all the participants of this Zoom meeting, if they have a YouTube video open, then please mute that, because otherwise you are going to get an echo.
Start off.
Yeah. Yes.
So just keep the Zoom meeting on the audio, the YouTube muted, so that we don't have echoes from the YouTube.
Hello. Yeah, Shreyas, can I call you in 2 minutes? I'm just starting off a meeting. Should I start, Kshitij?
Just let's get a go ahead from Rajesh.
Yeah, Shreyas, can I call you in 2 minutes? I'm just starting off a meeting.
Good morning.
Hi Pradeep, welcome.
Thank you. Hi, sir.
Hi.
Kshitij, shall I send you the video link? Not the video link, but the video.
Send it to Agnivesh because I'm running with issues here on my computer. So could you, Agnivesh, can you share your email address?
I'll just paste it on the group, sir.
Yeah.
On the chat.
Got it. Yes.
Sir, just send it to both of us just in case.
ठीक है.
Dr. Pradeep, if you could send it to both of us just in case if we have an issue. But you will be playing it from your computer, correct?
Yes.
I've got a message from Rajesh. The link has been added. What
So
does that mean?
we can start then.
Right.
So we can start.
Okay. Good morning, ladies and gentlemen. Warm, summery Sunday morning. We are welcoming you for the Bombay Orthopedic Society Master Shares program. This is the last of the Master Cares program of the 2020-21 season, and we have a very exciting morning set up for you. Today we are going to discuss problems of the ankle and foot, something which all of you see very routinely in your practice, and yet there are so many times when one is not sure what exactly is the way to deal with this problem, how do we investigate and how do we treat this particular problem. And to do this, we have got a very exciting program for you. Today, the program is different in the sense instead of having just lectures, we have primarily case-based discussions where eminent ankle foot surgeons from Maharashtra and Gujarat will be presenting difficult ankle foot problems. And these cases will then be discussed by eminent experts from across the world. I would like to welcome our two conveners, Dr. Rajiv Shah, very senior and very well-known ankle foot surgeon from Baroda, and Dr. Abhishek Kini, a young rising star in the Ankle Foot Society of India from the Hinduja Hospital in Bombay. Along with that, we have Dr. Pradeep Munot, a prominent ankle foot surgeon. Now one would call him a senior ankle foot surgeon in Bombay from the Reliance HN Hospital. We've got Dr. Malar Dave from Ahmedabad, the Dr. Sampath Dumre Patil from Pune. I'm sure you're going to have a very, very exciting time. Please, if you have any questions, direct it to us through the YouTube questionnaires, and we will make sure that your queries are answered by our panelists. So without much ado here, I'm going to hand over the mic to Dr. Rajiv Shah and Dr. Abhishek to convene the program from here on. Thank you.
Thank you, BOS. Thank you, Dr. Gautam Zaveri sir. Thank you, Swapnil Kini, for giving us this opportunity. I think today, because we have the master are all international, where because of this Zoom link, we had this opportunity where anyone we could approach, and they were kind enough to give us time. So we've recorded the sessions with our masters. First master is Professor John Corn, second is Dr. Judy, and third is Jean Boulot from France. So it's a recorded session, but at any point of time, any of the delegates want to ask us questions, they can ask us questions on our YouTube channel, and we will pause the video and we will answer those questions at that moment itself. So feel free to ask questions freely, and we are there to answer all of them. So I shall share my screen and we shall start the first session. The first session is on trauma by, I think is a Master of Trauma, Professor John Corn from Harvard. Second is with Dr. Judy Beaumont from the States. And third is on flat feet with Jean Boulot. So I shall share my screen. Before this, I'll take this opportunity to welcome our MMC observer, Dr. Ramesh Rajani, who's been very kind to us on a Sunday morning to give his time. Thank you, sir. And we shall start.
Good morning. Good morning. I'm there. Good morning. I'm there with you.
Thank you. Thank you so much, sir, for your time.
My friend, and then we'll go ahead with this my presentation for 1 hour, and 1 hour would be presentation by Dr. John. And is that Sampath joining?
I have requested Sampath sir that he said that he'll just freshen up and try and join with us. So I think that
right. Okay.
So I've sent the link to Mallas.
Start.
Yeah, and a quick start. So I think, John, thank you very much for giving us time today. Really appreciate on a Saturday night that you are spending time for us. And for my colleagues in Bombay, we have Dr. John Kwan, who's currently the Chief of Foot and Ankle Surgery at Beth Israel BOS Medical Center at Boston, Massachusetts. He's an Associate Professor of Orthopedic Surgery at the prestigious Harvard Medical School. Performed his surgical internship at Mass General Hospital and then orthopedic residency at Harvard. He performed foot and ankle fellowship at Mercy Medical Center in Baltimore and a thin wire frame mini fellowship at Portland, Oregon. He has published numerous books, chapters, and papers that we all have read, and his main clinical research interest is foot and ankle trauma, which we see a lot back in our country. And that's why it's very important, and it's actually a big honor to have him over here as part of our faculty for our local meet, which I think is the best part of being a virtual meet for us. So with these words, I think I would like to welcome Dr. John Kwan from Harvard to our meeting, and Dr. Rajiv Shah, we all know, is a stalwart in our country. And to match someone of John's stature, I had to keep Dr. Rajiv Shah in the opposite corner so that we can have a good, like a fair interaction between the two. I think I'll hand it over to the stalwarts from your audience.
Abhishek, audio is not playing. So share your screen. Stop sharing your screen. Click on share screen and share computer audio. Otherwise, we won't be able to hear the audio of the video. So.
My friend, and then we'll go ahead with this my presentation for 1 hour. If you could allow me to share my screen.
I have done it, sir.
Yeah. I, uh, 1 hour, 1 hour, 1 hour. 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 1 I think I hope I am audible and
Yes, sir.
my screen is seen. So John is one of a very good friend, and he is the real master for trauma in foot and ankle. And if you have any AOFS meeting and then the trauma is being taken care by him as a lead faculty. And so we are very fortunate to have John with us. Thank you, John. And let me start with my cases. So this is the case number 1. Male 23 had road traffic accident and had a crush injury of the foot and ankle. Had a compound crush fracture of talus and more so of the medial dome of talus, and had a compound comminuted fracture of fibula. And this was, I don't have the clinical pictures of injury because he was sent to me at the end of 2 weeks by the index surgeon, who did debridement and did a primary closure of the wound, which looked like this. On a lateral side, he has pushed in 2 K-wires, one K-wire which was from calcaneus to talus to tibia, and another K-wire was on the same direction from lateral aspect. So this is how it looked like on a lateral as well as posterior side. So when he presented to us, these were the X-rays on presentation. These 2 K-wires, one from the center, one from the lateral side, and this is how the situation looked like. These were the foot X-rays which showed a fracture of neck of the 5th metatarsal. So at 2 weeks, if such a patient presents to you, Dr. John, how would you go ahead with such an injury?
Yeah, thank you, Rajiv. Yeah, this is obviously a very bad injury in a young person, especially the involvement of the talar dome. I think that if this presented to me at 2 weeks, preoperatively, I would get a CT scan to better elucidate the pattern of the fibula fracture, obviously, as well as the talus, and look for other concomitant injuries. I think depending on how the wound looked, I may consider taking it for irrigation and debridement. You know, sometimes it's a little bit hard to tell which direction this is going in terms of the soft tissues. But when it's presented to me and it's clearly a bad injury, I usually will take it for my own IND. It allows me to also look a little bit more carefully at the soft tissues and whatnot.
Excellent answer. Because really we rely on our own debridement than anybody else's debridement, and we also like to have a look at the inside picture. So this were the CT scan pictures. This is a coronal image, and this is another coronal image, completely shattered bag of bone, kind of a medial part of talus. Also, patient had a fracture into the hidden neck of the talus with lot of comminution. K-wires were seen in situ, and you can see that there's a fracture of the neck of the talus. Body on the medial side was very much shattered. So I took that patient after 2 weeks of injury for revision debridement. I put an external fixator with a foot frame. I used K-wires for fibula to just maintain the length. I pushed in 1 K-wire into talus, 1 K-wire into tibia. I excised all dead pieces of medial talus. In fact, all those pieces were lying, like a bag of bones. They were lying free, so I had to remove them. I put in a cement spacer with antibiotics, impregnated cement, and applied a WAC dressing. So that's the dorsoplantar view. After the second surgery, we could close some part of the wound, but on a lateral side of the ankle, we had to keep it open, and then we took some stay sutures and we put in a WAC. That was after the WAC. And this is how the on-table picture looked like. That's the cement spacer. And this is how the x-rays looked like. So loss of this area, then cement spacer, fibula was reasonably aligned and held with the 2 K wires. And then this was the lateral image. So wounds were healing. Thereafter, we had 2 consecutive WAC applications at the end of 3rd day. And then there was a raw area, which was quite good. And it was temporarily skin grafted by a plastic surgeon. There was no infection. And this was at the end of another 3 weeks that the fixator was removed. There was no active infection. And this was at the end of 6 weeks. Cement spacer in, fibula fixed, trans-calcaneotibio-talar K-wire, and a cement spacer. And at this juncture, Zone, how would you go in? How would you do? I mean, how would you go about this? Everything is good, counts are normal, and parameters are good. He's a young patient, no infection, everything has healed, and now he's waiting for definitive procedure. Your thoughts, John?
Yeah, I assume he's otherwise healthy, no poorly controlled diabetes, non-smoker, healthy?
Yes, non-smoker, non-diabetic, young patient, healthy.
Yeah. I think there are a lot of options, and you know, of course, when you have a very bad injury like this, it's really a shared decision with the patient, and as best as they can understand, I think you have to present them the different options and the prognosis with those different options. So I think that if I was treating this patient, I would have a discussion about below knee amputation versus limb salvage. You know, if you are considering limb salvage, there are quite a few options. One would be to debride out the remaining talus and put a cement spacer in and see how he does. We have gone to recently 3D printing anatomic cement talus, but you know, Meyerson and other people have reported on how patients do with just a cement spacer. You know, in Mark's series, they didn't do very well, but it is a salvage option. Another option is to do an allograft talus and do a hindfoot fusion, or a femoral head and do a hindfoot fusion. You know, we were chit-chatting just now about total talus. That's an option. And I think probably the other option that comes to mind is a tibio-calcaneal fusion. And then either he, you know, wears a orthosis, or you consider, you know, doing a bone transport to make up length. There's a saying here that sophisticated surgeries are for sophisticated patients. And so, you know, not that many patients can undergo bone transport. So I think that those are the options. It really depends on what type of patient it is.
Yeah. And so what would you do to fibula if patient wants limb salvage? What would you do to fibula? How would you restore the length, and what fixation would you do?
Yeah, I don't know if I would, I'd have to think a little bit more about this, but I don't know if I would be addressing the fibula, because I think most of those options either entail some type of hindfoot fusion, where the fibular comminution and the fact that it's short and malrotated does not come into play. I think that if you did a cement spacer and or a total talus, which is certainly not a bad option in a young patient like this who could use the motion. I don't know if you would have to restore fibular length and rotation to get stability of the prosthesis. Dr. Shaw, what are your thoughts on the fibula in regards to those different options?
So I had a in-depth discussion with this man, and then he was not ready for amputation, nor he was ready for a fusion. He said, if I can get movements. But the issue was the affordability, and that is the issue in our country, because he was not really able to afford the total talus. And I was little worried that with around 50% of talus, or 45-50% of talus there, I was not so keen on sacrificing the same. So the problem I had were precarious soft tissue envelope at the end of 6 weeks, segmental short fibula plus comminution and bone loss. And the problem was 55% of talar body lost and how to replace. And the another problem was there was just a posterior shell of neck fracture and how to really fix it. Any ideas onto this if you want to fix such a fracture of neck of talus, John?
Yeah, I think this would be really an exceedingly difficult reconstruction or revision if you're thinking about maintaining his native talus. You could do some type of osteoarticular allograft, but I think he is sure to go on to avascular necrosis of that talus, and so when you think about putting allograft bone adjacent to a talus that will go avascular, I think that would fail relatively quickly. And I agree with you. You also have the problem of the neck being fractured and malaligned. I understand the financial issues, but I would be worried that this talus may not be salvageable.
Okay. So,
but he may not have other options,
Yeah, exactly. So with these problems on, I thought that precarious soft tissue envelope, I am going to go with a medial approach, and lateral approach would be at the anterior fibular border so that I don't have to go for a flap coverage. So that's how I thought of solving problem number 1. A segmental short fibula plus comminution and bone loss. I restored the fibular length with intermittent distractor and did a syndesmotic fixation for giving it stability and put in the proximal tibia bone grafts. And then 55% of talar body lost, I replaced it with the allograft talus. The issue with the allograft talus in India is that you don't get the kind of size what you want, whatever you have, which is best matching to the patient's talus, you have to accept. So allograft talus was ordered, and that was surgery number 4. Allograft talus which were replaced was removed, and then this is how the space looked like. It took in a medial approach, and then talus was then a marking on this allograft talus was done, and the body was prepared, and then it was matched at the level of ankle, because I thought that I allowed to compromise at the level of subtalar joint, but I did not want it to compromise at the level of ankle, and so I matched allograft at the level of ankle articular surface. A posterior shell of neck was fixed with 1 screw and a lot of cancellous bone grafts which were packed, and gel foam was laid over it so that bone grafts do not get dissipated. and I could pass one screw fixing talus neck with the talus body. Obviously, it looks little short, but this is how it has healed. This is at the end of 3.5 months that it has incorporated well. He is presently on mobilization, and long-term results are yet expected. Any comment, John or Abhishek?
I think coming from the Indian point of view, so where did you order the allograft from? Like from
Ramaya Lab, Bangalore. Yeah.
Pre-op also had a posteromedial tibial plafond.
Yeah.
Your thoughts on that? Like that?
Yeah, I just left it.
Left it up because in 6 weeks it would have just sat back in place wherever it had to sit back.
Exactly. I had to just leave it back. John?
Yeah, I think this is just really an amazing revision. Really technically unbelievable. I share your concerns. We'll have to see kind of how this goes and how it heals and things like that. But it gives him salvage options as well, right?
Yeah.
The talus that you're able to get, is it fresh? Is it freeze dried? What's the status of the allograft?
It's like freeze dried.
Okay.
And then supplied to me from a place from where it takes about 9 to 10 hours to come through 2 flights. So some person has to be sent personally to take it, and he changed 2 flights, and then he took a car drive to my city, and their instruction was that you have to use it within 24 hours of supply. So that's what we did. We did surgery early in the morning.
Yeah. And Dr. Shah, if the talus was a better match, would you have considered excising his talar head and neck and using the entire talus? Is that why you, what were your thoughts with that?
Yes, exactly. Because I had to create 2 fragments into 1 fragment, and then had to join the another head with the neck. So if I had got the allograft talus of adequate proper size, I would have replaced the whole of the talus. Dr. Ajoy, who is the head of this unit, which looks into this allograft replacements at Ramaya, Bangalore, has done such replacements. He has replaced whole allograft talus, and early results are good. He is yet to come up with his long-term results. But have you done it anytime, and what are your results like?
In terms of using the total
complete
talus?
allograft talus replacement, yes.
Yeah, so I've done it a couple times. The results are really pretty good. So we get a fresh specimen that is also relatively time sensitive. We do have a bit of a luxury where, you know, we get X-rays and CT of the contralateral side and have very, very accurate dimensions of the talus. And then we just wait until they have a matched talus. So very close. So I think that allows us to excise, to do a complete talectomy, right? And not have to worry about the patient healing the allograft to the talar neck, right? That's hard for patients to do. And I think because the size match is very close, the function of the transverse tarsal joint, the function is very good after fusion. So I think that does help a bit.
Okay, great. Abhishek, should I go to next case?
Yes, I think to sum up from our side, I think it's excellent. I think this case will bring about the availability of options that we have with MS Ramaya. And I can tell you that there is a bone bank coming up in Bombay too, which I think will help you get grafts much more in the next few months. And I think we don't lose anything by doing this, because even if this fails, you have still built a bone stock for the patient, which can at least save one of the 2 joints of the tibiotalar and the subtalar joints, which I think is a very important salvage option, as you correctly mentioned. When you're trying to salvage, I think the more we try, it's better for the patient. I think it's an excellent case, sir. Thank you. I think we can go
Thank
ahead.
you. So this is a case of a female 31 had a fall from height and had a fracture calcaneus, and so this was treated at US with open reduction and plate fixation, and then she had terrible pain. Her injury x-rays were not available, only post-operative x-rays were available, and this was a continuous to and fro communication on a video call as well as on a call from US to India. So this was her lateral x-ray. So this was done somewhere in a place which was nearer the Mexico in US, and where she sustained the fall. So this is how her lateral x-ray looked, and this is how her AP x-ray looked. Uh, comments, John?
Yeah, can you go back to the lateral?
Yeah.
And so, you know, clearly she has a malreduction. Her tuber is short. It's elevated. Her posterior facet is not elevated. That looks like the old lead Turnell plate from the original Synthes mini fragment set. And you know, I would be worried about non-union as well, although we know that's pretty rare with calcaneus fractures, but clearly malunited.
So now this was, immediate post-operative, and she had a lot of pain. So I was consulted, severe unrelenting pain, which was more at night. So I was worried about some kind of neurological involvement because of this long plate. It might have even damaged sural nerve. So my advices were asked on phone calls. So I said that get this implant removed. At least you will be off the neuritic pain. It may malunite, we're not bothered, but you at least get this implant removed as fast as possible. So implants were removed by the operating surgeon, and pain was reduced from 7 to 7 out of 10, but still she had a lot of burning night pain. And then it was at that time she sent me the x-ray, and this was the x-ray. John, any thoughts?
Yeah, you know, based on her symptomology, I would also be worried about nerve pain. You know, where those screws are placed, and certainly there must have been at least a percutaneous approach there. You know, we worry about the neurovascular bundle. Sometimes, as you know, with these calcaneus fractures and bad injuries, it's sometimes hard to tease out if they're having CRPS versus some type of actual iatrogenic nerve injury. But, you know, based on the position of those screws, a medial approach, worried about the tibial nerve or the branches of it.
So again, I was asked to give advice on phone. I advised watchful removal of medial screws plus a complete tarsal tunnel release. And so that was carried out. Screws were removed, and I do not know whether tarsal tunnel release was done, but patient continued to have pain, burning, had inability to stand and walk, and continued calling me. And so I had to advise that, okay, you need to come down to India, and I need to see you that what is going wrong in your case, and then accordingly we have to go ahead with surgery. So she landed in India 1.5 years later with this kind of lateral and this kind of axial image. Lateral, axial. This was the clinical picture. of this patient. So pain was same, lymph was there, 18 months post-injury with this clinical picture and this X-ray image. How would you proceed, John?
Well, I would get a CT scan because I want to know what the bones look like, what the joint looks like, things like that. I think I would consider doing an EMG nerve conduction study because it can be very, again, difficult to see to say this is RSD versus an actual tibial nerve injury. Another thing that you could consider doing, since all the metal is out, you still will have a little artifact, is getting an MRI. So you can actually look at the tibial nerve and see if it is entrapped within, the bone or things like that. But I think I would want to work up her neurologic signs and symptoms and then look at the bone more carefully.
Oh, great. So actually, NCV was done. EMG, our neurophysicians, they are not so keen on doing EMG for the small bones. And then NCV, they said that there is a sural as well as posterior neuropathy. Somehow this patient was sent twice for the CT scan, but she was so much claustrophobic that even with the sedation, she did not get ready for getting a CT scan. So the problems, so I suppose, John, you have to go in for surgical procedure for this patient. Without CT and MRI, how would you go ahead with?
Yeah. So, I would assume that her pain is coming from her subtalar joint. I would check clinically to see if she's having anterior ankle pain, but I assume she would from impingement, loss of the talar declination. I would do a bone block subtalar arthrodesis using just the vertical incision. I would probably use allograft bone. I've used these wedges before. The difficulty with the wedges is that you can't put a screw through it. You have to shoot around it. So I would probably use allograft bone. Because I'm using the vertical incision, I would find her sural nerve and excise it and bury the sural nerve. And I think I would probably do a tarsal tunnel release as well.
Okay. So would you do a tendo-Achilles release? Would you be able to gain the height without tendo-Achilles lengthening?
No, I agree. You probably would have to do something, but she's probably pretty tight anyway.
So I also thought in the same directions, and the problems in front of me was subtalar arthritis, talar dorsiflexion, tendo-Achilles contracture, heel in varus, heel shortening, sural nerve injury, posterior nerve injury, and claw toes. So I thought of addressing all of them, and obviously there was fat pad atrophy, which I don't have any solution surgically. So as I said, CT was not available. I explored and there was non-union between body and anterior fragment. Obviously, there was subtalar arthritis between body and talus. So I had to go in with iliac crest bone graft, where I tried to restore the talar declination angle. Obviously, I did the gastrocnemius lengthening and put in a bone graft joining body with the anterior process and fusion screws from body to the talus and corrected the heel varus. Together with that, I did the neurolysis and tarsal tunnel release on the medial side, and I did claw toe correction with excision, arthroplasty, and K-wire fixation. So, anything else? You address claw toes together with this, or at the second stage? Would you have done something differently?
Rajiv, the horizontal incision that you made, did you do that because you had to expose more of the body? I guess I would be worried about being able to close the horizontal limb because I'm gaining height.
Yeah.
What were your thoughts on that?
Yeah, I do agree, but I feel very comfortable. I have done a posterior approach, but this was already uh, extensile approach taken, and I thought that excision of the blasted lateral wall would be easier with the extensile approach, so I took that same approach. Obviously, I have not really been able to jack up the height as I would have loved, but still I could really close the incision. Yes, but that point is noted.
Yeah, I think you know I like to have my tourniquet down at 2.5 hours maximum. For patients who have peripheral vascular disease or poorly controlled diabetes or other factors, I like to take it down at 2 hours. I personally would probably have deferred the forefoot just because it probably would have taken me that long to fix the hind foot. But I think that as long as it's safe, there's no problems doing the forefoot at the same time.
Okay. Abhishek, any comments?
I agree, completely agree. I don't, most of the times the patients that come to me are not complaining about the forefoot. It's primarily the pain in the hind foot. So I would not have touched the forefoot, though I would have just mentioned that or discussed that in the counseling that in future if they have any problem, we would touch them. But I think the hind foot is done precisely. I think it is very difficult to get that height, especially in a such severe comminuted, malunited, non-united foot where actually the talus is not just horizontal, but actually it's a complete seesaw where it's gone up. So as much gain as possible. And I think the enemy of good is better. So I think you just have to leave it there.
See, typically what I do is I do my lateral approach, I do the clearance of the subtalar joint and everything, and then I release the tourniquet. So that essentially takes about 45 to 60 minutes. And then I take the bone grafts. During that time, tourniquet is released. And so there is a breathing period of another 15-20 minutes. And then I again erase it for about an hour and complete all other procedures. That's how I do. But yes, I agree. You could take forefoot in the next session also.
You know, my mentor, Mark Meyerson, used to say when we were fellows, too much surgery. And I never knew if he meant too much surgery for the patient or for the surgeon, you know, but, you know, we all have these cases where there's a complex problem and the patient wants their second hammer toe done as well. And it just seems, you know, but that's a great case.
Thank you, John. So we're going to the ankle case.
Rajiv sir, a few questions on our YouTube channel for you. Rajiv sir, are you there?
Yes, Abhishek. Yes.
Yeah. So I think Dr. Kunal Shah has asked regarding the partial talus replacement, that in case we discussed that, you know, you could have Dr. Ajay has done total talar replacement. He's asked a very important question that how does one get vascularity to that talus, which is allograft?
Yeah.
Like, is it required to put a vascular connectivity or some vascular transport also along with the bone for that talus?
Yeah, it's a fantastic question. Normally, you do not need a vascularized talus, and it's a very lengthy surgery. You are trying to put in the allograft talus, which works on a basis of clipping substitute inclusion of that allograft into the main bone. And even for the big OCD's talus, where you don't have anything, you do go ahead with matching allograft replacement. So it works, and a lot of reports in the literature has said that you did not go in for the vascularized talus. So it's a very morbid procedure.
Correct.
think the answer was, I think creeping substitution is what gets the vascularity and makes it imbibe over there, Kunal. The other question is on the calcaneum thing is Dr. Nikhil Agarwal is asked, like, how do you manage the subluxed peroneal tendons in such non-union cases, sir? Many a times they are kind of ensheathed in that bony structures.
Yeah, that's a great question. You see, very, very rarely you do need this procedure. In my series of 90 cases of malunited calcaneus, I had to go in 6 of my cases where I had to reconstruct the superficial peroneal retinaculum and bring that those tendons back into the groove. So you do need those kind of procedures in a rare instance.
Okay. Thank you, sir. So I think we can proceed with the talk, sir. The third case.
A female of 56 years who is gynecologist by profession and the husband is orthopedic surgeon by profession. She sustained fall from stairs and had a closed left ankle injury. And these were the x-rays. So looking at this x-rays, and this was the clinical picture that time. Do you suspect something, John?
Yeah, so she... Yes, her foot is plantar flexed, and we know there was a study that showed that may increase the appearance of the medial clear space. But you know, what's interesting is everyone remembers that plantar flexion increases the appearance of the medial clear space. But if you go back and look at that paper, it was on the order of tenths of a millimeter. So I think that may be overstated. But to me, you know, even without being able to measure that X-ray, the medial clear space is wider than the superior clear space, and you have a reasonable X-ray. You know, we all know that Tornetta and Eagle and DeAngelis, and we published a paper looking at swelling and ecchymosis, maybe not predictive, but as you know, a patient who has an isolated Weber B, their ankle does look quite a bit different than someone who has a medial-sided injury as well, right? So just based on her ankle appearing that way, I would be worried that this was unstable.
So would you take stress view, gravity stress view, or any other stress views?
I do gravity stress views. Admittedly, part of the reason why I do that is because we have a lot of research studies looking at these injuries. But I do not think it would be wrong to indicate her for surgery just based on that Mortis X-ray if you are someone who, you know, feels that they benefit from surgery with this. As, you know, obviously there's evidence to treat it non-operatively as well, but I probably would do a gravity stress view.
Okay. So husband thought that this is a simple ankle fracture himself as an orthopedic surgeon. He treated this patient, his wife, with the close reduction and percutaneous MIS fixation. So as a rationale for fibula and closed screw fixation on the medial side, and this is how it hid. So a small incision for rational introduction and a small incision for screw insertion for medial malleolus. John, Abhishek, your thoughts onto this MIS fixation for malleolar fractures?
I think it's a day one failure because it's a rotational injury and you put a intramedullary construct, which I don't think will provide you the stability that we really wanted this fracture pattern to have. Definitely would have, like, I needed a kind of a anti-glide or some plate which would have reduced it and held it in place.
Yeah. And would you do MIS fixation of medial malleolus?
No, never. I don't do that. Like, I don't do that. I'm not that.
But it's still united. Yeah. John, any comments onto this fixation?
Yeah, I think that the I don't think the problem was the non-displaced fracture of the medial malleolus. I think the problem was the concomitant deltoid injury, because the medial clear space was wide, not because of fracture malalignment, but because of the deep deltoid was disrupted. You know, the screw, the position is poor because the screw on the lateral is in zone 3. So that screw is abutting the posterior tibial tendon. We know that based on the studies from, you know, various people who looked at that. And I agree. I agree with Dr. Kinney's thoughts on the fibula. It's not anatomic. There's no rotational control. And if the fibula is not aligned and the deep deltoid was not addressed, if you get a slightly different mortise view, this is not, the mortise is not anatomic.
Yeah. So this went on uniting in this fashion. Postoperatively, she was mobilized at 4 weeks. Weight bearing was at 6 to 8 weeks. And this is how at the 1.5 years this X-ray looked. But she had a lot of medial pain, lot of difficulty in walking, progressive deformity at ankle and foot. This is how it looked. This is how it looked. And then it was a unilateral planus with the heel valgus. Abhishek, any thought what went wrong? And then what should be the treatment? A unilateral planus with a heel valgus.
I think here the problem is because the fibula was not playing its role of lateral buttressing to the ankle, it drifted in valgus. I think that's where I think the pathology started, along with the deltoid insufficiency, which has caused the whole problem. So I think that's what would be my line of thought process. Like, I think first to identify where we've gone wrong and then start reversing the wrongs that have happened. So I would be looking more at the deltoid and the fibula, which has kind of now mal-united, I guess, in more valgus.
I was also looking at John's comment about this MIS screw fixation, the way it has been put. So this was the one culprit I thought that must be there, which might have aggravated the situation. A deltoid injury together with injury to the tibialis posterior obviously is going to land up with a lot of problem. So this is what I thought, that probably the screw was endangering tibialis posterior tendon. John, is that the same thing you also thought?
Yeah, I did. I agree with Dr. Kinney. I think it's probably multifactorial. You know, I would doubt it was just simply injury to the posterior tib. You know, the deltoid may have some incompetence. The lateral buttress is slightly incorrect. So it's probably a combination of all three of these things that have caused that deformity.
So it was diagnosed as a case of iatrogenic injury leading to TP rupture plus a medial sided laxity because of deltoid insufficiency. Now, what would you do? John, how would you address this patient? He is really disabled, fit for surgery, wants to work for many other years, is a gynecologist.
Yeah, I think I would get a CT scan, and the reason why I'd get a CT scan is, one, to see how bad the malunion is of the fibula. If it's relatively mild, I don't think I would address the fibula. The CT scan would also be able to allow me to trace the posterior tibialis coming down to verify that it was injured on the CT scan. You know, I think another thing might be interesting is either a weight-bearing X-ray or to look at fluoroscopy to see if she has medial-sided incompetence. Because then my approach would be, if I did not have to address the fibula, my approach would be to make a longitudinal incision medially, take the screw out, repair the posterior tib, repair the deltoid, and you know, because this is a bit long-standing, you may also consider doing a calcaneal slide osteotomy. the soft tissue work may not be strong enough to correct her hind foot.
So John, you are a magician. You know to read the hearts and minds of people. Yes. So see, obviously, that clinical test. When you ask this patient to just try to recreate the arch, the laxity, the arch was slightly getting restored. So this gave me the diagnosis of tibialis posterior insufficiency, and the tibialis posterior isolated tibialis posterior testing test was also positive for tibialis posterior injury. MRI was obviously not possible. I did not go for CT scan, and I accepted the fibular malunion, and I went in for the same kind of procedure which you thought. So I went in with the medial incision. On exploration, the screw was through the, you can see the screw head here, it was through the tibialis posterior tendon, and you see, and then vigorous mobilization increased the tear of the tendon together with the medial instability. And then I also went in for the deltoid reconstruction. So I did a bent over waist deltoid repair and strengthened it and did a FDL transfer. I also did medial calcaneal slide osteotomy to really give strength to the transfer FDL. I did not do deltoid reconstruction with semitendinosus or any other tendon, but I did deltoid repair and augmented it with internal brace. So this is how the picture looked like. These are two anchors for 2.8 anchors for deltoid repair. This is the one for FDL transfer, and that's the medial calcaneal slide osteotomy. And she went on improving and almost gone back to her routine work. So any Abhishek, would you have done something differently than what I and John thought? And John, would you have used a graft for internal brace for deltoid reconstruction? Yes, Abhishek, then John, please.
I think I would have done the same, like absolutely the same. Just that.
You have used the Samiti graft?
No, sir, I don't use the Samiti graft. I think deltoid is a fan by putting a Samiti, unless I'm reconstructing in a extremely chronic insufficiency, then I would just put a graft. Otherwise, I think it's just repair, double breasting of the deltoid, try and get all the components. And that's how I would do it. I think absolutely the same.
John?
Yeah, no, I agree 100%. I would have, repaired the deltoid. I would imagine that if you stressed her under fluoroscopy, she would have minimal tilting of her talus. I probably wouldn't reconstruct the deltoid. I would just repair it, understanding that my calcaneal osteotomy is going to significantly improve my mechanics and protect the medial side, so to speak. So,
would you have used internal brace, John?
That's a good question. I'm trying to figure out what my indications are for using the internal brace with lateral ligament repairs. I would consider it, but I think it would depend on when I got her into the OR and I stressed her in eversion, how much her talus tilted. If she had a lot of incompetence, I would consider it, but if not, no.
Okay, thank you. So, another case, 29 years old male, had a run over injury, had a crush injury of forefoot. His records tell that there was a vascular injury of dorsalis pedis and tibialis anterior, anterior tibial artery, and they'd done some coiling for that. and he had a comminuted fracture of first metatarsal. I don't have the injury pictures because he was treated elsewhere, but these were the injury x-rays. So this patient was taken for the debridement by index surgeon. Vascular repair was done by a vascular surgeon, and you would see in the next x-rays that there are some coils seen, and then a primary closure and an intramedullary K-wire was passed at surgery number 1. This was the skin situation at the end of 5th day of primary debridement and closure. As is said by our seniors, as is taught by us, that the primary closure of an open wound has to be very, very judiciously done. So this wound started breaking, and then surgeon went in for surgery number 2, where he did debridement. After 10 days, this was the picture following the debridement. So 2 surgeries was sent to us at the end of 3 weeks with an infected wound and exposed first metatarsal and a K-wire in situ with good vascularity. And this were the x-rays, lateral, AP. So zone, this is at the end of 3 weeks of this crush injury foot with discharge in a healthy individual with a K-wire like this presenting to you at the end of 3 weeks. How would you go ahead about this? John?
Yeah, so he obviously needs another debridement. He is young. There is a lot of Dr. Shaw?
I think we just lost him. I think his network would have just crashed. Maybe we'll just wait for him to log in.
Okay.
So John, till Dr. Shah comes in, what all have you found out are your indications for the internal brace? Because in my personal experience, I've removed them more than I've put them in. So other people where, to be very honest, the Arthrex guys have like pushed them to put them left, right and center. I'll come back and get it removed. What are your thoughts on it?
So the thing that I find very challenging is there are some patients who, despite me doing the surgery exactly the same way, have some laxity afterwards. And they, same post-op protocol, compliant patients, no underlying connective tissue disorders, and some people just are loose afterwards. And I don't necessarily know why. And so, you know, you can't put the internal brace in everybody, right? But I think we need to try to meet it. So, you know, previously, if someone had connective tissue disorder, morbidly obese, or they already had a ligament repair, I would do a Brostrom and do a split Evans, split the peroneus brevis. I'm starting to convert to doing the internal brace, but I'm still working through what my indications are. How about you? When do you decide when you have instability?
I think for instability, I would predominantly do biologic like Brostrom, and off late, my mentor in UK, Karthik Hariharan, would get a raise, or rather would raise a periosteal sleeve and bring it down. So that would be more, so I believe that is more biologic than putting the brace laterally.
So Abhishek, are you able to see?
Now we can hear you, sir. So
okay. So as sorry about it. As John said, at the end of 3 weeks when he came to me, I thought that no question, this is a draining wound. I need to go in. I need to debride. So I went in. I debrided the wound. I removed K-wire, and then there were dead bone pieces which I had to excise. I put in a spanning X-Pix, took the deep culture and applied VAC. And this is how the picture at the end of debridement looked like. And then this was VAC number 2, VAC number 3, and then surgery number 4 was in form of skin graft coverage, temporary split thickness skin graft coverage with an indigenous external fixator. So again, next 4 weeks, skin graft coverage well taken, no discharge, count normal, culture sensitivity negative, no pain, wounds are cool, and he is a young guy. And this is the X-ray picture with this kind of defect and a spanning X-Pix. So John, what would you do at this juncture?
Yeah, this is a really difficult problem. It's a long distance to span with allograft bone. You know, I don't. You could always have the discussion about a TMA, although. Aside from his Liz Frank injury, the rest of his foot is pretty good, right? It's the soft tissue coverage is good. He's perfused. His osseous anatomy is pretty good. You know, I think I would talk to the patient, see what they would want to do. I mean, you may consider doing a spanning allograft with a long plate construct to see if you can stabilize the first ray. Even if you got a pseudarthrosis, maybe that might be good enough.
Okay. So I discussed with the patient, no question of amputation. He had been referred to me to salvage the great toe as well as foot. I also discussed with him the option of doing a fusion with a long autograft. I also discussed with him that we can try 3D printed metatarsal replacement with the collateral ligaments created, but without the surety of longevity, how much would it last? Then he opted an option of kind of fusion with the autograft. Abhishek, would you have thought in some different direction for this case, young patient?
No, I think I would take a maybe proximal middle third fibula and put it over there and fuse it with the proximal phalanx. I think that would give me autograft and the length that I want to restore it. I would do a MTP fusion, from metatarsal to this.
So yes, the problems in this case was a bone loss, what to use and possible issues. So John, if you are to restore the length, would you use fibula or would you use iliac crest?
Well, I think if you, for that length, you could use fibula, and then you could use vascularized fibula if you have access to a surgeon who can do that for you. I think that would be a better option than iliac crest. The iliac crest is better cells, but you need quite a bit.
Okay, but I was little worried about the strength of the fibula, and I did took the X-rays of the fibula of this patient, and I was really worried about the strength and the consolidation time of the fibula. So let me show you what I did. The another problem is the fusion position. So John, how would you obtain the correct fusion position for this patient if you're doing first MTP fusion with the graft?
Yeah, I think if you're using a graft, you would have to use, the foot plate and make sure there's a little bit of dorsiflexion of the toe. For my regular MTP fusions, I have found this to be a little bit unreliable. So I actually look at the dorsal cortex of the first metatarsal and the proximal phalanx. Some podiatrists did a study, but if you look at the dorsal cortex, it's almost a 0-degree angle. And so, I use a flat plate, so no elevation of the plate, and that seems to put the toe in a good position. Because they don't have their native first metatarsal, I think that you have to use a foot plate like this.
Okay. And then the third problem was soft tissue coverage. And there was a skin graft. When you really go in, maybe you may lose the skin graft, and where to get coverage from. So these were the problems. And I thought that I'm going to go ahead with iliac crest grafting, which would be stout. And if you go about 1.5 centimeters from anterior superior iliac spine, you have a pretty straight iliac crest graft for another 4.5 to 5 centimeters. And then for that problem too, I got hold of cup and cone reaming. So I wanted to ream the part of the graft which was to form the head of the metatarsal, and I wanted to ream similarly male as to female kind of reaming for phalanx. And then we planned for sural neurocutaneous flap to cover the defect. So this was surgery number 5. I am just going ahead with this case because thereafter we are looking forward to see the cases of John. Right, Abhishek? This should be the last case.
Yes, sir. Yes, sir.
Yeah. So on table, after refreshing, this was the gap left out. So I took the iliac crest graft, and then I passed a K-wire and I started shaping the graft as per the head of the metatarsal with this kind of reamer. And then I shaped the proximal phalanx with the cone type of reamer. And then I put in the graft and fix it temporarily, had a clinical check to keep it into 10 degree of dorsiflexion. And then this bone graft was supported with one medial orthogonal plating, and bone grafts were packed into the area where some fused spaces were there. This is how the X-ray picture looked. I went right up to the medial cuneiform and the proximal phalanx, 2 orthogonal plate. That's the lateral view. And we could close it with a bipedical flap. And the incision was categorically taken anterior to the skin grafted area. So we could cover this area with just a bipedical flap or release incision. So comments.
I think it's great. I think it's a great solution. It's the best biology the patient can get, and I've never taken such a big piece of the iliac crest, but now I know that you can take quite a bit of crest. Really good.
Abhishek, would fibula have given such a strength which this?
I feel fibula gives good strength. Yes, at both the ends of your fibula, you need to put cancellous grafts that you can take from, I take it from the calcaneum, you can take it from proximal tibia. And since you have a plate on top, the fibula being the good cortical bone that you have, it gives you the strength that I think we want on the medial ray. And that osteointegration time, if you put cancellous grafts at the end, I think it would not have been, I would not have thought that would be a problem for me. I would still go with fibula, but yes, I think my challenge, I think here we got out because you got a relatively straighter iliac crest. Sometimes we may not get, because we get a curved iliac crest and then placing it correctly would have been a challenge. But I think what good things that learning points out of this is like how you use the cup and cone to make sure that that also press fits into your graft area. I think that's a good learning point. I think similar cup and cone you could have done on the proximal end also, because anyways that's
proximal end there was a sharp piece of bone, and then it was a medial as well as lateral bone. So this graft got jammed between these two.
Fantastic. No, because if that was a dead bone and you were about to nibble it out, I think having the cup and cone trimmers would have helped us there also.
Yeah. No, but then there was a good length of the bone into which this graft
just shoved in like a shovel, I guess.
So I'm going to stop sharing, and we're going to go ahead with Dr. John with his cases. Over to you, John.
Just give me 1 second, okay? I'm going to take a very quick break.
Yes.
Fibula, Abhishek, I feel is sometimes when you have a longer length, it takes long time to consolidate. I've been doing a bamboo hut technique for TTC fusion where there is a defect. But the fibular length which I've taken there is not exceeding 3 centimeter. We did publish it into Techniques in Foot and Ankle journal. But when you have a length which is to be bridged onto a bone which has to weight bear during gait, I was little skeptical to use fibula. And then when I went through the literature, there was only one case reported, and in which they're using iliac crest. And every literature which I saw for a revision first MTP fusion, they're using iliac crest. No report whatsoever with the use of fibula has been reported. But yes, when you are using 2 plates and a fibula, I was also worried about passing few screws into fibula, which I wanted to. Yes, John, you are there. Go ahead, please.
Yeah. Okay, so I'll go ahead and share my screen. Are you able to see my PowerPoint?
Perfect. Yes.
Okay, great. Thank you so much for having me. My cases, I think, are going to be a little bit more bread and butter, maybe a little bit less reconstruction, but certainly want to know your thoughts and your approaches to these. So the first case is a 56-year-old female, and she was involved in a motor vehicle accident. And she has this injury. It's a closed injury. It's an isolated extremity injury, and she's otherwise neurovascularly intact. Any initial thoughts on this?
Yes. I'm going to span it and then taking that patient for scan. But initially, I guess I'm going to span this patient with an external fixator involving the foot frame also.
Okay, yeah, that's exactly what we did. And these are her CT scans. I fully recognize that with very complex injuries like this, it's very difficult to understand the nature of the injury by isolated shots. But you can see on the sagittal imaging on top, she has clearly a body fracture. There's quite a bit of malrotation of the body. There's a transverse fibula fracture. On the coronals below, you can see that she has quite a bit of malrotation of the body fracture with the associated medial malleolus fracture. You can see that we have our X-fixed pin in, and I think these type of injuries, it's always good to get the CT scan after you get alignment restored. Otherwise, it's very difficult to look at. And these are her axials. I highlight this image on the bottom left because, at least for me, this was the key to understanding, for me, how to think about fixing her talus fracture. This is the medial side, and you can see that the medial neck and body is in relative continuity, where everything else is just kind of a bag of bones. Dr. Kinney, how would you approach this? So the swelling has come down, and now you have this injury.
I think this is actually a very challenging one, especially because the body component has come out laterally. Had it been medial, I find them relatively easier, because once there is a medial malleolar osteotomy, like fracture already there, so getting that in place makes life little easy. For this, definitely a dual incision, anterolateral or lateral, which will kind of get me access to my body fragment, and a medial incision, which will help me, like when I push my lateral fragment in, to check if all those, or if how well I have got my reduction and everything. So definitely a dual approach. Make a liberal incision, do not struggle with your incisions, and try and recreate the jigsaw that you need to kind of fit it back.
Yeah, Dr. Shah, Rajiv?
Yeah. See, you have a fracture of the fibula as well as fracture of the medial malleolus. So you have two natural osteotomies. Obviously, it's a infrasyndesmotic fibular fracture, but you can still use that. So I'm going to take a dual approach, and I'm going to flip both medial malleolus as well as lateral malleolus, more so lateral malleolus, and reduce the way Abhishek said, some jigsaw puzzle, some manipulation with a joystick, and then start fixing the body, and then from there come to the front, to the neck portion. And I'm going to pass the screws from posterior to anterior, taking care that I don't go much higher onto the dome of the talus for this fixation. Sean?
And why in particular would you pass P to A screws? What are your thoughts on that?
Yeah. So if you see this fracture, the posterior piece from the body, so because the fracture line is quite posterior, for fixing this, I think you don't see my cursor, but for fixing this fracture, you're going to pass posterior to anterior screw. For the body fragment, you're going to pass horizontal screw, headless compression.
Okay. Yep. So this is basically how I teach the residents how to approach very complex articular fractures, and I break it down into 3 simple steps. So I do spend a lot of time, as we all do, studying the CT scan. I want to know which of the osseous articular fragments are important and which ones are not important to try to salvage and build to. And then once I identify the important pieces, I figure out which approach do I need to access those pieces, and then it becomes just technical aspects of this. So I agree with both of you. This patient certainly deserves a formal anteromedial and anterolateral approach. So anteromedially to access the talus, but also to eventually fix the medial malleolus. And anterolateral, I thought more so to expose the talus than to worry about the fibula fracture. And so you can see that we're basically building this together and putting a bunch of headless screws in. I think, Rajiv, the reason why I was able to get away with not putting P to A screws in was because the medial side was mainly intact. So I could build to that side and put my screws across. So we went ahead and did that, and then after we did that, we put a plate on the fibula, That small K-wire is holding just a small portion of the plafond that I left in. And, with the transverse fibular fractures, it's easy enough just to a cannulated screw in. And not perfect. She did have troughing of her talus that you can see here. And this reduction is not perfect, but certainly a pretty good salvage. So she did fine for a couple of years. And eventually she went on to have, post-traumatic arthrosis and ended up having a fusion, which was a relatively easy fusion to do because her alignment was relatively good. One of the things that we are starting to investigate, and I want to know your thoughts on this, is doing a percutaneous tendo-Achilles lengthening at the primary surgery. So in my experience, these patients who have bad hindfoot trauma, they always get tight. They always get stiff, and you're always fighting it in the postoperative period. And so we started to do them prophylactically. What are your thoughts on that?
I think this is a worth thinking aspect of it. Even my trimalleolar fractures with a posterior fracture and then posterolateral or posteromedial approach, they also find it very, very difficult to get the dorsiflexion. So later on, we do think that should we go ahead and do the gastrocnemius release? So doing it prophylactically sounds very, very interesting. And, we would be very keen to learn your results, and maybe it would be worth following.
Dr. Kinney, what do you think?
My question is, after doing your prophylactic Achilles lengthening, you would still immobilize this patient for how long?
Yeah, so most patients get complete immobilization for 2 weeks. And that's mainly to let the soft tissues calm down. So they're splinted for 1 week, wound check, splinted for a second week, and if amenable, their stitches come out. I would allow for gentle range of motion at that point, but I think where you're going at with this is whether you can mobilize the patient in the setting of the Achilles lengthening. Yeah.
Correct. So whether to do it on day one or to do it as an outpatient procedure if he needs it later on is something that we need to look at. So there are, sorry sir, I'll just complete. So there are people in pediatric orthopedic who do ultrasound guided needling of the Achilles tendon and get the length. So I feel that might also come into consideration in adult population. But again, the biology is way different in a pediatric versus adult. And actually, I don't think, I completely understand looking back in hindsight that yes, the Achilles gets tighter, but whether the Achilles gets tighter on day one or in the next 2, 3, 4 weeks is the real question. And I don't think we have an answer yet on that, but I think it's open.
Abhishek,
thank you.
Yeah, Abhishek, what I do, whenever I do gastrocnemius release, I always immobilize those patients in maximum dorsiflexion, which I have got. Because I am yet to see any dorsiflexion contracture, but we have seen a lot of plantar flexion contracture. So cases where I do gastrocnemius lengthening, I immobilize them in a splintage for 2 weeks, 3 weeks, whatever time I am to immobilize into dorsiflexion, little dorsiflexion, then into neutral. So that whatever length I have gained remains stretched. So the issue of immobilization for 3-4 weeks and then again going back into the contracture does not come.
No, I think just being a devil's advocate, then why not fix the fracture and immobilize it in complete dorsiflexion without releasing the Achilles? Maybe we might, that might be a good control or other randomized study where you do a release in one group and you don't do a release in one group, but you immobilize all of them in maximum dorsiflexion and then come up with our results. And I think that might be a good study to I think, John, I've given you a paper.
John, yeah. John, your
Okay.
thoughts? Your thoughts on this point?
Yeah, I think many patients with bad hindfoot trauma struggle with dorsiflexion, and I wonder whether putting them through a second recovery and a second surgery several months later is worse in terms of their longer term prognosis than just doing it initially. I don't see a problem with weakness from the lengthening in adults. I do have some patients, and I wonder if you guys do too, is having people who have pain in the Achilles. So you've done the lengthening, it's healed, but they just have chronic pain from the lengthening, and so that's a problem. But we'll see. We'll see.
I think the other reason why I am a little skeptical about doing it on day one is because I firmly believe that the restriction also comes a lot from adhesions that happen to other muscle tendon junctions, especially the posteromedial side. Especially the bleeding that has happened has a lot of pro-osseous factors. It's a very fertile pro-osseous factor. So I think that causes a lot of scarring in people who are little prone to scar. So not just the Achilles, but the FHL, FDL, and all those muscles which are posterior to both the malleoli would also scar, not just tighten, but scar. So I think by releasing the Achilles, we are not actually addressing the main cause, because Achilles otherwise is way far behind the bones that we are addressing. So maybe, that's my thought. That's my just general thought process about the procedure on day one. But I think if it's going to help and literature supports that, I think it will be a practice changing decision, I guess.
Thank you. This is a 50-year-old, and she has this bad Hawkins too. Any different thoughts on this injury compared to the one we just saw?
I think equally bad with a lot of combination.
Yeah, so sometimes our residents will get a CT scan before reducing. So we went ahead and reduced this, and one of the techniques that I like to do for certain hindfoot injuries is just to put a single pin in, an extra-articular pin, and then you can see that we have somewhat restored the alignment. But I agree with you, a lot of comminution medially and laterally. Another thing that was interesting that I didn't necessarily notice beforehand, but I picked up in the OR, is that she has a very flat posterior facet to her calcaneus. And so I didn't pick that up beforehand, but that did come into play when we did her surgery. So just a quick thing about these hindfoot pins. We have used these for many different types of injuries. And this is actually my treatment of choice for open calcaneus fracture. So this patient has an open medial calcaneus fracture. And so what I like to do is make a small lateral incision, and I'll put a laminar spreader in just to get the tuber back down out of varus, and then put a pin in, and then let them sit like this for about a week and a half or so. And it's very safe as long as you are not too medial. So you can see the pin there. And as you trace it up, you realize that you just cannot be medial, because if you're too medial, then you'll get into the neurovascular bundle. And this is a study that showed it's relatively safe. But one of the things is that, so you can see the image on the top left, it's malaligned. And, we can tell that because it looks too flexed. The subtalar joint is not correct. And as we know, if the subtalar joint isn't lined up very well, it's probably malaligned. And so one of the things that I have I have figured out with Hawkins 2s that are really unstable, or certainly Hawkins 3s, is I will put a K-wire across the malleoli. So I will get the body reduced, and because it's so unstable, I will K-wire it, and then I can build the neck to it. When it's very unstable, too many things are moving at one time. And so you can see that once we have the body K-wired, then I'm able to get a more closer anatomic reduction. You can see the posterior, the subtalar joint looks better aligned here. But this was really difficult because of the comminution. So even though we had dual incisions, we had no key-in whatsoever. So we were trying to basically just go on the radiographic contour and look at the declination. Rajiv, I agree with you. Whenever I can, I do try to get P to A fixation. We know that that's been shown to be the most rigid. So certainly a little bit technically more challenging when you're supine, but this is how we do it. And the patient did fine. No AVN. And you can see in this case that we used fully threaded screws to get no compression. Sometimes I'll put a fully threaded screw medially so I don't tip it into varus, but we put 2 fully threaded screws because there was no need for compression and things like that. Thoughts, comments?
Yes. John, what I do, whenever I reduce the posterior fragment of talus, I pass a K-wire from calcaneus tuberosity to that fragment, fixing the subtalar joint temporarily. And sometimes I require to keep that K-wire for 3 to 4 weeks. So that's what I do. Secondly, for a head and neck fracture or a neck level fracture, I'll pass a K-wire, reducing the head into the right position. I would pass a K-wire from navicular to, navicular to talar head. So that also fixes my fragment. And then I try to solve my jigsaw puzzle. That's what I do. But I did like your idea of pushing K-wires through the malleoli as well. That can also as well work. For our many orthopedic surgeons, if you could narrate the tricks you use to reduce the dislocated body, because I've found that many times that body, in spite of people trying, comes with the dislocated body, and surgeons are really not able to reduce that. So if you could come up with your techniques and thoughts on to reducing the body.
Yeah.
Dislocated body.
Yeah, I think this is a bad Hawkins 2, right? Usually they're not out the back that far, but Hawkins 2, it just simply getting the foot back, dorsiflexing, getting the foot pushed back, and then splinted is usually not a problem. I think the Hawkins 3s you're referring to are much more difficult. Usually what I say is during the reduction temp, you obviously need adequate anesthesia and analgesia. You have to bend the knee to get the triceps surae out as a deforming force. And then I think you have to simply distract the foot away from the tibia and then try to apply direct pressure on the talar body to push it back around. I don't know. Do you have any other techniques or thoughts on how to do that?
Yeah, but so do you use a bone punch to really push it back? Because pushing it with the thumb, sometimes you get really fatigued.
Yeah, oftentimes these patients are initially being managed by the resident who's doing the first evaluation, and they are setting up the conscious sedation and all those other things. Generally, if we can't get it in closed, the patient goes to the OR pretty expeditiously. At least in the emergency department, we do not make any small percutaneous incisions or try other things. How about you? What's the
So if it doesn't get reduced by the close means, I do not really wait for further manipulation. I go in and I take this patient and put a generous incision, as you said, and I put a strong Hintermann distractor with a pin into the lower part of the tibia and pin into the calcaneus, and I distract it with it, because whatever femoral distractor, kind of femoral distractor you use, sometimes that distraction force is not that great. So I use intermittent distractor strong to really give focus distraction at the level where I want the distraction. I also use joystick. Sometimes I'm forced to use joysticks through the articular surface, and if not, then I proceed to the osteotomy, maybe medial malleolar osteotomy or a lateral malleolar osteotomy. But I had a case where a fracture dislocation talus was manipulated by one surgeon that could not be reduced. Then he referred it to the another orthopedic surgeon who tried and who said, okay, reduction is done. And then patient was sent to me for a definitive fixation, where at the end of the 3 weeks with 3 approaches, I tried to put that body back. I could not reduce. And I had to excise the body, and I had to go for total talus replacement for that patient. Had you had such a case where the body could not be reduced and you had to excise the body?
No, because I haven't had a case where there was a later presentation of a dislocated talar body. The ones, the Hawkins 3s, and I've probably only have seen just a handful of 4s, but the Hawkins 3s come right away. And so, you know, if they can't get close reduced in the ED, we take them to the OR, and if we can't close reduce them, we make an incision, and then we push the body back, put an X-fix on, and then come back another day.
Abhishek, you had any experience of delayed presentation of fractured dislocation talus?
I think, again, to be very honest, only 2. But I think as I am not well trained to use the femoral distractor. So I also do what you did. Instead of Hinterman, I put what we call, I use I have a Charnley's compression clamp. I used it in a distraction mode, but the same calcaneum and talus, brought it up to length and just put the bone back in place. By the time it had come, one was I think 3 or 4 weeks, one was 6 or 7 weeks. So had already explained the chances and other complications. So you just reconstructed the bone stock. One of them needed a subtalar fusion later on. The other one has not yet come back. Both were like outstation patients. By the time they came to me, they were delayed. But to be honest, the ones that you're talking about, only 2 in my practice.
Yeah.
John.
Okay. So this is more of a reconstructive case. This is a 66-year-old male, and he had a talus fracture some years ago. This was treated at an outside institution and sent to me. So his initial RAF seemed fine, and then he developed AVN. Healthy 66-year-old, active, relatively active, and so he had failed appropriate conservative treatments, and this is what he has at this point. So options at this point. Dr. Kinney, why don't you start? What do you think? You're on mute.
Yeah. Sorry. I thought I said I will discuss everything with the patient, right from just plain implant removal, total talus, TTC, everything, because right now at present he doesn't show much of arthritis on his other joints like the tibial plafond as well as posterior facet of the calcaneum, but the talus is not looking healthy. The other option is whether, I don't know, like sports medicine guys do it, implant removal and BMAC into the void areas, but I'm not a big fan of BMAC. But I think that might be one of the other conservative options.
Yeah. Rajiv, what would you do?
So obviously with the good subtalar joint, if I have an access, I do not know whether you can really excise the bad part of the body, fill it with the bone and do the ankle replacement over top. Ankle replacement is obviously not available in India, but that's one option. And then the option of the fusion and option of the total talus replacement. And I am a big fan of total talus replacement. If patient is really able to afford, in the view that the ankle replacement is not available, I might go in for the total talus replacement for this patient.
Yeah, that's similar how I was thinking. I didn't think he was a great candidate for a total ankle because of the progressive collapse of his talus. But yeah, you know, we had a talk about both those options, and because he was a little bit older, I think we opted for a fusion because of that. So this is what I was telling you before, Rajiv, before we when we were chit-chatting about how, you know, we can get a very closely matched talus in the U.S. To the contralateral side, and so I wagered my fellow to see if he could get the avascular talus out in one piece, and he was able to do so in about 30 minutes. And so you can see the avascular talus next to the matched talus, and we go ahead and prepare it and put all the autograft and all the bone adjuvants, and so go ahead and do a hindfoot nail. This is, you know, we were talking about the tail navicular capsule, right, for the total talus, but this is an anchor that we use to repair the capsule here, and he went on to do great. This is him at 4 months, and doing pretty well. You can see he has some, you know, pelvic girdle weakness, but at 4 months he was very happy. So pain-free, and so doing well. I don't know if he would have been pain-free with a total talus, maybe, because I agree with you, his joint surfaces look pretty good otherwise, but we thought this was the best option for him. So,
John, what about you not doing a TTC fusion and just putting this allograft talus as a spacer?
Yeah, that's an interesting thought. I didn't think about that. I think that, I actually, not in this talk, I have it in a different talk where I show 3 different videos of someone who has bilateral ankle fusion, bilateral TTC, and bilateral total ankle replacement, and you cannot tell the difference between their gait. And I think that if you put the foot underneath the tibia and it's plantigrade and the patients are pain-free, they do really well, even if you're fusing certain joints. And so I think we just thought the best option was to give him a hindfoot fusion than to try to give him joint motion.
Great.
That's an interesting thought, though. I don't know if I've ever considered that. Have you had any experience with that?
As I said, one of my fellow and who is the in charge of bone bank in Ramaya Medical College, Bangalore, Dr. Ajoy, has done 2 such cases where he has replaced the allograft talus, autograft talus with allograft talus. So for a comminuted shattered talar fracture, he is used, not that he has gone for the CT scan of the opposite side, but as much matching talus as possible, because he has an access to bone bank to which he is the in charge. He has put in allograft talus, but the long-term results are awaited.
Okay. 65-year-old, he had a fall off the ladder, closed injury, Sanders 3, maybe 4, depending on which pieces you're counting. Dr. Kinney, what's your approach? What is your surgical approach? When do you do surgery? How are your thoughts on this?
So definitely comminuted depressed intra-articular fracture. I am 99% extensile lateral man. Like, it's something that my team, everybody is extremely well used to. So getting that position and all, it makes my life easy. I'm a relatively quick surgeon, so approach doesn't take time. So So extensile lateral more often than not, unless someone really wants the MIS. They should ask it from me, then only I give them MIS. But extensile lateral, open, reduce, fix. Oh yeah, time of surgery once the wrinkles come, once the soft tissues are adequate for going in. No rush in going in, can go in between 10 to 20 days once the swelling is down.
Okay. Rajiv, thoughts?
Yeah, I'm a big fan of primary fusion in the Sander 4 type of bag of bone type of calcaneus fracture. So once tissue and everything settles down, wrinkle sign comes up, I go in and I do the reconstruction to the best of the ability, fixation and primary fusion with a bone graft from iliac crest. And I think last AOFS I had my presentation onto doing a case series where bilateral Sander 4. On the right side, all those fractures of the right side were reconstructed. And the fractures on the left side went in for primary fusion. And all of my patients, they were very happy with the fusion side because it was a single shot surgery, one surgery, good fusion rate, and they were back in action quicker. So to me, till the time I have a randomized study, which is a strong study with an evidence that the Sander 4 would be better with fixation than a fusion, I am going to do fusions, primary fusions for my patients in India.
Dr. Shaw, so this is, you know, it's not terribly short. It's in a little bit of varus. There's some obviously comminution of the posterior facet, but you probably could just do a fusion in situ for this, or AF and fusion in situ. The ones that are really more displaced and you plan on doing a primary subtalar fusion, do you do anything initially? Do you K-wire? Do you percutaneously get it out to length? Do you do anything? Yes. Yeah, what are your thoughts?
Yeah, so I put these patients into a external fixator where I use our indigenous external fixator, which is called Josie's external stabilization system. And I put in a wire into posterior tuberosity of the calcaneus, to wire or two into tibia and into foot, and I keep them distracted till the time I'm going in, because otherwise it becomes very, very difficult at the end of 4 to 6 weeks to really reconstruct. Obviously, I'm always ready with my gastrocnemius release if required.
Okay. Yeah, so I do almost exclusively sinus tarsi. I think the only patient who gets a extensile lateral is someone who has a operative calcaneus fracture who presents very late to me. And even then, I will consider doing sinus tarsi and doing osteotomies through the sinus tarsi approach. But I'm early, and then I do sinus tarsi. This is the injury that for sinus tarsi people worry about. Because, you know, a Sanders 2, when you have 2 pieces, it's much easier than a 3 or 4 where you have intervening pieces that you have to reduce sequentially. And so this is, you can see here in the operating room, one of the techniques I like to do is put a laminar spreader in, and you can see that allows me to do some work. It somewhat pushes the heel back. And then what we do is we serially elevate each fragment up. This is where, you know, Roy Sanders and other people will advocate for the bioabsorbable pins. So once you elevate one facet, one portion of it, to put a pin there and then cut it off. This way you have that elevated, then you can elevate the next piece and the next piece. But we don't have that in my institution. So once we have each piece elevated, you know, my resident has to skewer the piece and hold it reduced. And so you can see we are building it up. And you know, as we know, the primary fracture line nearly always passes just posterior to the anatomic angle of Gossain. And I remember in this case, my resident was asking me here, well, it's elevated, but why do we have a gap there? And the gap is because the heel is still in some varus, right? So the posterior facet is elevated up, but when the heel is still in varus, you have that gap. And then once you take the heel out of varus, that gap closes. And so, and then we use a plate and screws and things like that. So you can see the Broden's view, not perfect, right? But reasonable. So.
Yeah.
Thoughts, comments?
Yeah, great reconstruction.
Absolutely, and sinus tarsi great.
Great. But you know, John, if you are committed to sinus tarsi approach and you figure out that you're really not able to reduce, because such kind of situation, when we do extensile lateral approach, sometimes I bring all the fragments out on the table and thread a K-wire, and then I put it back and thread it medially. So suppose you are committed to sinus tarsi approach and you feel that you are not able to reduce sandal 3, sandal 4. How would you go about it?
Yeah, so usually we use time from injury to time to surgery as a rough measure of fracture consolidation, right? So patient is a week out, we know we can reduce it percutaneously. If patient is 3 weeks out, we worry about it. And so if it is an operative calcaneus fracture and they're 2 weeks, 2.5, 3 weeks, 4 weeks, what I will do, because my preference is to use the sinus tarsi approach, in the operating room, I'll make a tiny little incision and put a freer or a right angle in underneath the posterior facet and see if I can move those fragments. If I can, I make a sinus tarsi approach. If there is absolutely no movement and it really is consolidated, I'll do an extensile lateral approach. So I will test it percutaneously before I start. I do not think it's safe to do a sinus tarsi approach and then convert to an extensile lateral. I think that's very risky, even though there's no literature saying we can't, but I think it's very risky. The other thing too is, sometimes even with advanced consolidation, I will do a sinus tarsi approach and I will literally osteotomize the posterior facet, osteotomize the primary fracture line through that approach to get a reduction. Those are much harder to get anatomic, of course, but I had a lot of problems with the extensile lateral approach. So, are there any techniques, Dr. Kinney, that you use to try to mitigate the wound healing problems with the extensile lateral? Anything special you do? Anything different?
Make sure that you're bang onto the bone, and that flap that you raise has to be a proper osteoperiosteal flap. That flap, getting the flap is important, I think. Use sharp knives whenever you're going in. Change the knives frequently. And I think make it liberal. So if I have to, that's what my, say, if the access should be right up to the posterior facet. So if you extend that line from posterior facet posteriorly and inferiorly, the flap has to be that big. The problem happens is when you retract too much and your incisions are only on the calcaneum, but your incisions have to go beyond the calcaneum, superiorly and distally. I think you might take some time, but I think it just helps you get them back.
Yeah. Yeah, I agree. Yeah, Rajiv, go ahead.
Yeah, I, over and above this, that complete length and breadth of the flap, and whenever you are on the bone, you are going right deep up to the bone. Whenever you are at the soft tissues in the distal end, you're going light with your incision. And then no touch technique, you're lifting it. And whenever I put in with a retracting K-wire, between the K-wire and the flap, I always push a weight gauze or a pad. So my flap is always kept weight. That is the one important thing I always make sure. And second thing, putting a drain. Initially, I was not putting a drain. That did give me some issues of the flap at the corner, but putting a drain, and then again suturing, meticulous suturing into 2 layers, starting from the ends and coming right up to the apex. By and large, these things have not given so great a wound problem like they are expressed.
Abhishek, we can't hear you. While Abhishek audios, let me thank Dr. Rajiv Shah, Dr. Abhishek, and Dr. John Kwan for a fabulous session, fantastic cases. I think great learning for every one of us onto the various minor details and techniques of dealing with complex ankle foot injuries. Before we start off the next session, I would like to invite our organizing secretaries for YROC 2020 Unlocked to tell us about what is the progress about YROC. Are we going ahead with it on 19th to 21st March? And what do we look forward to during those 3 days? Mandar?
Thank you very much, sir. First of all, I would like to congratulate the conveners for today's session, for this fantastic session. Coming back to YROC, we are going ahead with it. As direct answer to Dr. Gautam Zaveri, just to set all the rumors to rest. We are on for a fully physical YROC 2020 Unlocked. It is going to be held at the Renaissance Convention Center. We are happy to inform you that we have got permission for a full physical conference. It is going to be held with excellent social distancing, with excellent provisions of the entire screens, with all the precautions which have been mandated and even more by the government and all the authorities. We have got good enough permissions for this, and registrations are closing fast due to the overwhelming rush. Coming to the program highlights, we have the first day full of excellent theme-based symposia where we have international centers of excellence collaborating with us. These are all the top of the line international centers who have agreed to collaborate with us. These are the faculties, Dr. Neerav Pandya, Dr. Kishore Murthy, all of them are absolute who's who of their own field. On the second day, we have our own Dr. Karkhanis sir, who's going to give the RJ Katrak oration titled as a tribute to my teachers. Our Dr. Sangeet Gawale sir, who's going to be talking on neglected fractures around the knee for the A.K. Talwalkar Symposium. We have got excellent sessions on Stump the Professor, the free paper and the video session, and a very good session on wealth management for orthopedic surgeons, something which was really missing in the last 1 year by Dr. Nitin Bagli at the end of the day. The last day, we'll have Dr. Daryl Dilima, who's our own Mumbai pass out, who's going to be giving the Dr. K.T. Dholakia eponymous lecture. Thus, friends, we are on for YROC. Welcome to YROC. We are going to take great care of you with all sorts of precautions. Please do come from 19th to 21st of March 2021 at the Renaissance Convention Center. Thank you very much.
Thank you, Mandar. It sounds very exciting. I think the arrangement made are perfect. And on behalf of the Bombay Orthopedic Society as Vice President, I welcome each and every one of you, request you to register for the conference. And I'm sure you'll see a bigger academic feast than we've had in YROCs all these years. So looking forward to seeing all of you on 19th to 21st March. I would like to request our secretary, Dr. Swapnil Kenny, to say a few words about YROC as well as about the Bombay Orthopedic Society academic programs that are on.
Right. Thank you very much, Gautam sir. Let me appraise all the audiences on YROC as well as our other academic and non-academic programs. We've almost finished all our courses except for the advanced arthroscopy course, and we are very proud that we were able to conduct all our courses online and they were oversubscribed. As Mandar has already appraised everybody, we shall be conducting YROC Unlocked this year from the 19th to the 21st of March. A very important announcement for all our members, that is BOS members only. The annual general body meeting of the Bombay Orthopedic Society will be held on the 19th of March from 5 p.m. onwards. And I would request all our members to be there at the Renaissance Convention Center to attend this meeting and be a part of YROC 2021, YROC Unlocked. Thank you so much.
Thank you, Swapnil. Another great reminder from our secretary, Mandar, as to how Bombay Orthopedic Society is the leading provider of academic orthopedic education across India. Bombay Orthopedic Society has been having fantastic courses for the last 20 years. And with each passing year, the number of courses are increasing, the variety of courses are increasing, and the subscription from all over India is becoming more and more. You can now follow Bombay Orthopedic Society on our YouTube channel, on our Facebook and Twitter accounts to learn what is going on with Bombay Orthopedic Society, what is new, and how you can get involved with the society in these programs. So without much ado further, I would like to now give the mic back to Abhishek, who will probably take questions on the previous session and then move on to the session 2. Abhishek. Abhishek, we still can't hear you. Rajiv bhai, would you like to take over while Abhishek? Abhishek, it might be worthwhile if you join back.
Yeah. Could you just pass on the questions which are there on YouTube?
The problem is that his mic is not working for some reason. So while he does, if you have other questions. Rajiv bhai, you showed us a lot of very interesting cases and the post-op results were fantastic. They were really challenging. Do you ever tell this patient that there is nothing I can do? It's better to get them amputated early. The function will be restored faster and you will be back to work faster than if I try to do this whole reconstruction business?
Yes, that's a great question. You know, it's very, very important and vital for us to discuss every possible option for the treatment which these patients have. But, you know, the amputation in our Indian mythology, psychology is such that people are not so keen on to getting it, though sometimes it's a better option than the long-lasting treatment. So all the options are discussed with the patient and thereafter patient takes up one particular option onto which we are working.
But which are the patients in which you would specifically refuse? If patient says, I do not want an amputation, but the wound is this bad, like you've shown in your first 2 cases, which are the patients where you say, I can't do it, either you get amputated or you find some other surgeon?
So the factors which matter for me into taking this decision making is a bad infection. Number 2, the kind of function patient is going to get at the end of the reconstructive procedure. Number 3, the vascularity of the limb, neurological issues, these and the socioeconomic condition of the patient, which may not be so good that he can warrant 1 or 2 other surgeries. So these are the times where I say that it is better to get amputated, and then I'll straightforward refuse to treat that patient if he is not willing for the amputation.
We see a lot of patients who are treated for ankle foot injuries and then they come back with claw toes at the end of the treatment. What should the average orthopedic surgeon who's treating these injuries take care to prevent the clawing of toes, number 1? And number 2, the incidence of compartment syndromes in the foot.
Yeah. So obviously these claw toes are because of the hidden compartment syndrome or a missed compartment syndrome. And we are many times obliged to go in and fix very, very early without really taking care of the compartment issues, which results into this claw toe deformity. Those early cases can definitely be treated with the physiotherapy and passive manipulation. Those cases which have a flexible deformity definitely respond to this kind of management. But those which have gone for the complete rigid clawing of the toes would definitely require surgery in form of excision arthroplasty of the PIP joint and the releases of the metatarsophalangeal joint.
Rajiv bhai, good morning.
Very good morning, Pradeep. Go ahead, please.
Fantastic session. I think it was great. A lot of learning points, of course, from you as well as Dr. Pawan as well. I think just few questions I'm just looking at till I think Abhishek comes back. You know, the iliac bone graft which you took, which is a large bone graft, I think that was an excellent idea. Just one question, would somebody have a problem wearing a trouser and a belt on that? Have you found any problem with that patient?
Yeah, so you have to be very, very much watchful that you don't destroy your anterior superior iliac spine. And you have to be at least 1.5 to 2 centimeter behind anterior superior iliac spine. Otherwise, the issues of trouser would be there. So that at the same time, there is also an issue of injuring the lateral cutaneous nerve of the thigh. So you need to be behind anterior superior iliac spine about 1.5 centimeters or 2.
Great. Sorry, one more question from Kunal Shah.
Sorry, Pradeep, we frequently use long iliac crest strut grafts in the spine. And really speaking, as long as you take care to stay behind and go, that is not much of an issue. It is more of a Western issue than an Indian issue.
Sure. Excellent. Yes. Another question from Kunal Shah, Rajiv bhai. If ankle is not fused and only nailed through calcaneum, will implant fail over a period of time due to implant fatigue?
Absolutely. Because you need to prepare the ankle because it is the subtalar and ankle joint. When you are putting a nail through the calcaneus into the talus through the ankle, you need to prepare the joint because the nail will not withstand the loads and nail would get a fatigue fracture. Even people used to initially think that the subtalar joint did not require to be prepared, but it is also mandatory that if subtalar joint is not prepared, then the issues would be generated from subtalar joint. So if you are passing a nail from calcaneus talus right up to the ankle, you need to prepare both the joints, ankle as well as subtalar joint.
I think that's what I'm also finding it. A lot of people are not using, but I would say it's almost at the cusp of abusing the TTC nail now. And even for primary fractures or pilon fractures, a bad pilon. But I think you make sure that the joint is prepared very well. I think Rajiv bhai, the point is very well put up that you have to prepare the subtalar. Like even in the literature where subtalar joint was told that you can ignore it. I think I have myself seen 2 failures of the nail through the subtalar joint. So both the joints need to be prepared.
Thank you, Pradeep. Thank you, Rajiv bhai. Yes. We'll go back to Abhishek now. Abhishek.
Yeah.
We still can't hear you, Abhishek. I think we should move on to session 2. If you have the recording, can you play the recording here?
I think it's recording. So I think, hi, I'm Abhishek Kini, and I think on behalf of Bombay Orthopedic Society, I would like to welcome Dr. Judy Bahoma, who's from the States, and I think Dr. Rajiv Shah, our past president and eminent foot and ankle surgeon from Baroda, would like to take it forward from here.
Good morning, everybody in India, and good evening, ma'am, in US. It's a pleasant duty on my part to introduce Dr. Bamar, who serves as Associate Chair of Academic Affairs, and she's a Professor, Department of Orthopedics at the University of Rochester. Over and above providing clinical care, she holds the position as a Director of Clinical Bioinformatics Care for the US healthcare system, and she's a Board of Director of Accountable Health Partners, ACO, for the Rochester region. Ma'am is a past president of American Board of Orthopedic Surgery, American Orthopedic Foot and Ankle Society, and Eastern Orthopedic Association. She is currently the president-elect of the Promise Health Organization, which is an international society of clinicians, researchers, and healthcare personnel who are interested in advancing patient-reported outcomes in the medicine to measure and improve the care provided to the patient. Dr. Bamar has published over 100 peer-reviewed papers and book chapters. She is a board of trustee for American Journal of Bone and Joint Surgery and a reviewer for clinical orthopedics and related research, Foot and Ankle International, American Journal of Bone and Joint Surgery, and Journal of Orthopedic Research. We are very, very much fortunate to have ma'am with us today as one of the master, and Dr. Sampath and Dr. Abhishek are going to take forward few of the case presentations where we are going to take views of man. So welcome ma'am. Indeed, it's a great pleasure to have you here as one of the master. This is for the first time that instead of having a regional master or master from our country, we have masters from the world sharing their opinions, sharing their care, and sharing their opinions. Over to you, Sampath and Abhishek.
Thank you, sir. I think Sampath sir, can you please share your screen and take cases?
Yeah, please allow me to share the screen.
Okay.
Well, let me take a minute to say thank you, Dr. Shaw, and thank you all for letting me come present my thoughts on these cases. I'm really honored to do so, and I can't wait till the time that we can get back together in person and see each other. Thank you.
Hello, madam. Welcome. And we are going to present you some cases, and they may not be ideally done here. Some of them are cases done by ourselves, and we want your opinion how they should be managed ideally. Am I audible clearly?
Yes, sir.
Yes.
So she's a 40. We have a case from forefoot, midfoot, and hindfoot, so that and Achilles. So that we have views from Judy ma'am. She's a 43 years lady, and she came to us mainly for painful plantar callosity under second metatarsal head, and she had hallux valgus and crossed over deformity of the second toe. It was not the deformity which was bothering her, but this was her X-ray, and actually this was the plantar callosity here which was bothering her a lot, and quite painful. On examination or blood investigation, she was not having any medical disease like rheumatoid arthritis, but this is how she presented to us with mainly painful plantar callosity. So any thoughts, ma'am, about how do we go ahead? These are obviously standing X-rays, and second toe is second MTP joint is dislocated.
Yes, I know you know all of this, and really we're speaking to others to educate others in regards to this. So first, you'll know, if you go back to the clinical pictures, you would have guessed that this was dislocated because of the position of that toe, even without an X-ray. The second thing is the plantar callus occurs because the toe is sitting on top of the metatarsal head and is driving it to the ground. We also know that with bunions, they transfer load. So they're, you know, if we look at the bottom of her foot, we've noticed the plantar callus, but we also know that there's somewhat almost baby skin underneath her first ray because she's really not putting any weight onto that. And so all that transfer load is going over. Untreated, this may result in the third actually becoming dislocated next, because as the second is off-weighted, the third will be the next vulnerable toe to start to go through this process. It may take years, but it may not. You can already see this, the third starting to sweep into the defect that's occurring as the second toe's gotten out of the way. The other thing you notice is she's got a pretty significant flat foot. Her great toe is pronated. She has a flat foot. And when I see people like this, I take their hands and I try to manipulate their fingers, and their fifth finger in particular to see if they're hypermobile, because they may have laxity that occurs, and that will obviously impact what your treatment plan is. So now you can see from the contralateral side, she's starting to pronate on that toe as well. Oftentimes I say what happens on one foot may not happen on the other foot, but it's kind of oftentimes does. So you'd want to educate the patient a little bit about that too. So now go to the x-rays. And what we want to look at from a standpoint of the x-rays is we're interested in that second ray and how long it is relative to the first ray. And you can see that that metatarsal is longer than the first ray. You can see that there's a wide intermetatarsal angle and that there's a valgus deformity, that the sesamoids, the medial and lateral sesamoids, are completely uncovered in the first web space and almost en face, so they're rotated. So you know that there's pronation. If you didn't have the clinical pictures, you'd be able to see this in your own eye because you'd know that that was rotated with that degree. And then what we want to see is we want to look at the lateral, the standing lateral film. And do you have a standing lateral?
Sorry, I have not posted up here standing lateral X-ray.
Her standing lateral may give you some idea of whether or not there's gapping at the first TMT joints, or even some subluxation at the first TMT joint, or even naviculo-cuneiform joint. So those, the standing lateral may give you some additional information in addition to knowing that she has a flat foot. In my mind, hearing all of that, then I have to talk to the patient and I have to find out if she says, isolatedly, my big problem is that plantar callus. Then there's a little bit of education you have to give her. That present a doesn't sound crazy to them, because it's a lot when I just came to you for a callus. So you really have to go through that process. But of course, you can always try non-operative things, and the non-operative things you could try would be a metatarsal pad or a custom insert to try and off-weight and put the weight on other areas of the foot and off-weight the area of the callus. I'm not sure that that will be so successful in this case, but because I know that, there's a lot of sandal wear and different types of shoes that are utilized, you may be able to accommodate for that. But at the age of 40-something, I think that probably a surgical solution would be a better choice for this lady, but I always give people both options.
Agreed, ma'am. So that second metatarsal head was so adhered to the callosity that it was really painful. And when I explained her about flat foot and hallux valgus also contributing to the callosity, she said, "Oh, is it really? I mean, cannot you only treat corn? Can you just please excise corn?" And actually, she did it one or twice before she came to me. She was just getting treated for that corn, what they say, not the callosity. So I offered her deformity correction, and let me show you what we did, and then we will sir, Rajesh has.
Unmute yourself, sir.
Sir, unmute yourself.
Pardon me? Oh, what's my answer? Oh,
no. Rajesh has wants to say.
Yeah. So the question to Judy, that if the patient is having flat foot together with hallux valgus deformity, what would be your algorithm? Do you address both? Do you address one? Do you address one after another? What should be the algorithm?
Yeah, so, I didn't talk about what surgical solution for this. I would not address the flat foot at the time for the 4-foot correction. I actually would just go after the forefoot, and I would probably do a lapidus and a second metatarsal shortening osteotomy and a PIP fusion for this. And I probably would add an Aiken to that lapidus procedure. Now, her other options, and I know that this isn't popular in India, but in the United States, I would also offer her the potential for a fusion of her first MTP joint. And the reason I would is because the possibility of that working and being very stable for a very long time is actually excellent. So I find out about what she does. So if she says, I'm a long distance runner, well, a great toe fusion is not my best option. But if she says, oh, you know what, I don't do that much activities, I walk around and I, might occasionally hike and do some things like that, a fusion might be the good option for her with the second correction, with the shortening osteotomy and the PIP fusion. I do not repair the plantar plate. I haven't repaired a plantar plate in years, and it hasn't been my experience that I've needed to, although I think other people have had good results with that. I think you have to decide what you do well and what works in your hands, and that scenario worked well in my hands. But I wouldn't do anything less than a lapidus in this, because I think she is going to be ligamentously lax.
Right, ma'am. We offered her deformity correction. We discussed with her, and I was keeping in mind the oblique first TMT joint and a lot of IMA angle, which is significant. I offered her MTP fusion, and I did Weil's osteotomy of second. It was very difficult to get the exposure even for Weil's osteotomy, and we did fusion of first MTP joint and Weil's of the second metatarsal head. This was so displaced that even to get access to do the osteotomy of the second metatarsal, it was difficult. And look at this. I don't fix Weil's. I just allow it to slide to whatever portion it allows. And once we did MTP fusion, even IMA angle corrected significantly. And this is how is post-op. This is pre-op. And look at the callosity. I did not touch the callosity at all. It was so adherent, so painful that pre-op she came to me only for callosity. But once we corrected deformity, we never reconstructed arch. I did not do anything for flat foot. I'm just offering her custom-made insole, and she's a household worker, so she's not running, and she's at present very happy with the MTP fusion and the outcome. So I want to ask you, ma'am, whether MTP fusion is an aggressive surgery here. If you would have salvaged MTP joint and went for lapidus, and about Weil's osteotomy as well. Do we anytime want to reduce this dislocated MTP joint?
Yeah, well, first of all, I think that the fusion's a great choice. I love that. And I think having had the conversation with your patient to find out what they do and what's going to meet their needs is the key. It's the key. Because patients are disappointed when you haven't learned what they want. And, the Weil, it might have been not powerful enough for this. She might have needed a shaft osteotomy, but it's very hard to say. I do some shaft osteotomies for that amount of dislocation and shortening. It was, probably 1.5 to almost 2 centimeters shortening, right? Or, of overlap of your base of your proximal phalanx on your metatarsal on those initial x-rays. I wouldn't have necessarily gone after a Weil on number 3 and 4. I might have just done number 2. I might have just done number 2 and maybe number 3 if I thought I needed the extra amount. I don't like to shorten number 2 shorter than 3 because I know I'm going to get into trouble then. But I think all in all, I think looks good. You're probably going to do fine. I'll back this up to asking you a question. What salvage would you do if she still had trouble with her second toe, if it became painful? What's the answer to that?
A second MTP joint using. So probably in this case, I did second and third vials as well. I forgot to mention because then parabola is still maintained. And MTP joint is dislocated. So I don't have any option other than vials. I won't do fusion or excision of head as such. I was thinking of excision of head, which is very commonly done in rheumatoid, but not in this case, I would have thought.
I think you're wise not to have taken the head out because you saw that the third was already going over there. And I think if you took the head out, the third would start to move into that space. So I agree with you there. I actually thought you did a fourth vial too. I just couldn't tell. But so just
yes, sorry, ma'am. Yeah, I have done second and third through a separate incision. I forgot to mention that. I think it is seen. Yeah, there is a separate incision as well. So we have done. I'm so sorry for incomplete information. We have done third and fourth vials as well. Yeah.
So just to say that if the second toe went bad, if it became arthritic because it's still somewhat overlapped and irregular, my answer to that is to take the proximal phalanx out of the second toe. Now it'll leave that toe a little bit, it's not exactly floppy, but it'll be not as stable, but it'll still be a spacer so that the third won't come into that. And that's my backup plan for your toe if it gets into that trouble. It may never get into that trouble. She may be happy as a lark with this for a very long time because she's got a stable first ray, which is the key to this whole thing. But if it's problematic, I wouldn't hesitate to take the second out. The only cosmetic problem with that is the second toe may look a little shorter than the third toe. So the woman needs to know that outcome might happen. So, but I wouldn't take the met head out. I'd take the proximal phalanx space out.
So that is an important message for our listeners that do not touch on the head side in lesser toes. Better to touch the base of the phalanx, particularly in the second or lesser toes. Is it true?
If you have to, down the road.
Yeah. Thank you. So we did it almost 10, 12 years back, and she's quite happy with the result. Dr. Abhishek, anything else you want?
I would like to ask Judy, like now we talk about the hyperbola in the forefoot, but when you are fusing the first MTP, how big a role does that still hyperbola have? Like, because you anyways, now actually the loading is not going to be on the metatarsal head. It's going to be entirely on the MTP, like metatarsal head and the proximal phalanx. So does the hyperbola still have relevance after you have fused the MTP?
Right. The instability may be at the first TMT joint. So when you fuse the great toe at the MTP, it will transfer the stress of that ray up to the first TMT joint. So I think I heard you say that you had put your patient into a, arch support or encouraged her to potentially wear an arch support. And I think that's a very good idea because I think that will protect you a little from that problem. I don't have a standing lateral, so I couldn't tell if she had some instability of that joint or not. So, going with the idea that probably she did not because you did a fusion on her, I think that's, maybe a not important item at this stage. The other thing I just want to mention is I think the positioning that your great toe is in is really important. You put her toe in about 10 degrees of dorsiflexion, it looks like just from this oblique. I can't, because I don't have a standing lateral, I'm not exactly sure, but it looks like you're about 10 degrees of dorsiflexion, which is great. And she still is in a very small amount of valgus. If you put them too straight, their IP joint gets arthritic. So you need to make sure that you leave them in a little bit of valgus because that will decrease the stress across the IP joint of the great toe. I don't know if that answered your question about instability or hypermobility. No. I tried.
No, Judy, my question was about the hyperbola that we talk about, the metatarsal heads. Like we want them to come in a hyperbola.
Oh, I see. Hyperbola.
So,
yeah.
If we are fusing the first MTP, does the principle of hyperbola still stand true, or you can actually get out of it without considering the exact hyperbola?
No, I think it still holds true because even though the first doesn't really count, the second, third, fourth, and fifth still count because they're not fused, you know, nor should you ever fuse those lesser MTP joints. But I think it still is important because if you had, just for example, say that you shortened the second quite a bit and you left the third long, then that third will get the weight and that third will be a problem. So you still need that nice curve. So I still think it is important.
Yeah, one more point I want to ask you, ma'am. Is it interesting that I have touched only MTP joint and how nicely it corrects IMA angle? I mean, I have not touched the proximal joint. I mean, what is the reason for this particular? We have not at all touched the TMT joint, but how nicely it corrects the IMA angle.
You know, I think that way back when I first started practicing, they thought that maybe you needed to do something at the first TMT joint and at the MTP joint to correct that IM angle. And you know, that has been totally proven to be false. That once you line up the great toe properly with your fusion of your first MTP joint, the stress and on the TMT joints aligns it. And I think one of the things that people do wrong with a great toe fusion is they don't realize you have to squeeze together the first and the second to close that 1-2 angle and then balance the phalanx onto the metatarsal head of the great toe. If you just bring the phalanx out of valgus and you put it on the great toe metatarsal head, when it's still wide and fuse it, you will fuse them wrong. So you need to close it and then fuse it. And just like you did. So it's obvious to me you knew you should be in the masters category because you did a great job with this fusion for sure.
Thank you, ma'am. They were great learning points. Shall we go to the next case, Dr. Abhishek?
Yes, sir, please.
I will omit next 4-foot case and we'll okay. Otherwise,
we can take it, sir.
Yeah, we'll take 1 4-foot case and then, ma'am, she is a 26-year lady, typical rheumatoid, and she has bilateral deformity of toes, and of course, again, loss of medial arch. She was medically optimized, but she has on and off is not taking medical treatment for rheumatoid arthritis, very cross hand deformities and feet deformities. This is about her left foot, and now we will concentrate on right side for this presentation. We have operated on both, but for today we will just discuss right side. So this is a lady, 26 year, and these are her standing x-rays. And I will just show you the clinical picture as well.
And her primary complaint is that she
again painful callosities under on the plantar aspect. and pain at the deformity site as well. And main complaint is also she's not able to put on normal footwear. They are so drifted medially, so she was unable to put normal footwear as well.
Yes, so you can see clinically that she's in varus, and she's somewhat windswept where her other toes are going with her great toe. And if you look at the X-rays, it's interesting that she has rheumatoid because she doesn't really have erosive-looking disease. Her metatarsal heads are not really erosive. But we recognize that an inflammatory arthropathy also has instability with their soft tissues. So they have I always say, an unreliable soft tissue envelope. So you can't just reconstruct these. You really do need a fusion in this case of her first ray. And then her lesser toes are going to be quite deformed, and you need to decrease the tension across those joints. And the rheumatoid forefoot reconstructions that have been done for years and years and years, probably 50 to 60 years probably, have really held up the test of time. And although some people have investigated the option of trying to save the metatarsal heads by doing shortening osteotomies and realigning it, I have just been taking out the metatarsal heads for the last 25 years, and I've had really good results with that when I fuse the great toe. You cannot do it without addressing a stable first ray. So in the way back in the day, they might have done like a Keller, a resection arthroplasty of the proximal phalanx space of the great toe, and leaving that great toe unstable, and then doing a metatarsal head resection of the lesser toes was a terrible operation. So the answer to this lady's problem would be, in my hands, a first MTP arthrodesis, and a second, third, fourth, and fifth metatarsal head resections. And I would pin these toes. I saw that there was a DIP that was deformed, and probably some other IP joints are a little deformed. I do an osteoclysis, where I just straighten them out with my hands and pin them straight after I took the metatarsal heads out. So the second, third, fourth, and fifth would have a osteoclysis and pinning, and the first ray would be fused. Again, the flat foot, she has a very, very segmentally flat. I call it flat, flat, flat foot because all the joints are flat. Yeah. I would address those. I just leave I would just address the forefoot. And if necessary, and she needs some sort of little arch for her foot, this is almost a skew foot, where her hind foot is in valgus and her forefoot is adducted. That's why when you said she was a rheumatoid, I was like, oh, she's a skew foot, but she has rheumatoid too. So anyway, that's what I would do.
Let me go through what we did. Same thing, MTP fusion. Helix virus was so significant that even lengthening medial side tissues was really an issue, because I took medial approach, dorsomedial approach, but really it needed a good release. I released adductor helicus as well, because it was again very tight, and unless I did that, I did not get the correction. And exposure of the head, good position of great toe, and she was so thin, fragile. I never wanted to take other incisions for other lesser toes. So probably, I should have addressed, but with great toe, when I address great toe, I thought it will give support to others as well. And this is how she's doing well. Almost we have done it 10 years back. Now we have done on both the sides. She is doing well on both the sides. I never touched these toes. Fortunately, I would say that that was to be done, but I did not do it just for the sake that she was too thin, and I never wanted to take multiple incision that time. But fortunately, she has done absolutely well. I mean, all other lesser toes have also been stable now. Any views?
Excuse me?
Yeah, please, ma'am. Your views, ma'am.
Yeah, oh, my views. Yes, I think that's fantastic. Like I said, I was surprised you gave her the diagnosis, that she had the diagnosis of rheumatoid arthritis because she didn't have erosive disease. So you figured out that her laxity could be corrected with just correcting your great toe, which is fantastic. So I would celebrate this outcome because it's great. I think it's fantastic. I went down the other walk that the metatarsal phalangeal joints of the lesser toes were painful to her, and that's why I would have taken them out. Now, if they weren't, then yours was a great choice. Dr. Shaw?
Yeah. So, ma'am, for our viewers and listeners, how do you manage pale toe after rheumatoid forefoot correction surgery? A toe which is pale after surgery.
How do I manage it, or?
Yes.
What do you mean? Where is the toe pain?
Pale toe, a toe which is white, bluish after rheumatoid reconstruction surgery. Lack of vascularity.
Oh, lack of vascularity, I see. So it most likely will be a lesser toe, first of all. The great toes usually have enough blood supply that that's not the problem. And if it's a lesser toe problem and you pinned it, you can pull the pin. If, like in this case, you didn't operate on the lesser toes, so it's unlikely you're going to have that problem. But if you did do the metatarsal head resections and the toe did not pink back up, I would pull the pin for sure, and hope that did the trick for you. If it didn't do the trick for you, I still would give it time. You could put some nitroglycerin paste on it because that allows some arterial augmentation, if you will. But there's a possibility you could lose a toe by doing these things. And that's part of the consent process. In my practice, I can remember one rheumatoid patient that I lost a portion of their toe, but they were completely dislocated, more like that other lady that we did first. She would have had a risk to actually have a loss of a toe because you're pulling her down into a position where there's going to be more stretch on those tissues, and that vascular supply might be impaired with that. This case, these weren't dislocated toes. Matter of fact, they were sort of windswept. And it would be unlikely that these would get dysvascular, but there are other toe positions, dislocated toes in particular, that would be problematic. Is there anything else that you had ideas about, Dr. Shaw?
We do put warm saline packs because nitroglycerin paste is not available here. And obviously removal of the K-wire and then just doing a syndactyly.
I sometimes drop the foot at the side of the bed too, just gravity. Sometimes that helps it.
Thank you.
If the dressings are on, you got to loosen the dressings. If they're in the recovery area, loosen the dressings, of course.
And as Madam said, results of rheumatoid reconstructions are really rewarding. I mean, we have done it way back, 10, 12 years back, and she's really doing good. Just MTP fusion, but she has really done good.
Did you do the other side?
Yes, we did, ma'am. I have not posted here, but we did, and she's really doing good. Again, on other side as well, I just addressed MTP fusion because now I was confident with other side, and she has done well on other side as well.
That's excellent.
Yeah. Dr. Abhishek, anything?
So, like, I would like to take Judy ma'am's view on how does she plan coronal deformities of the lesser toe? Like, if there is a medial or a lateral drift, then how do you plan your? Sir, can you show the X-ray?
Yeah, I will.
So, if you're doing this, like, if you are planning to correct or salvage the MTP, how would you plan your vials, or what osteotomies would you do to correct the coronal plane deformities?
Mhm. You know, I always do web space incisions to get to my MTP joints. So because when they heal, then they don't contract the toe up. You know, what I don't like is when people put them straight dorsal, because sometimes then the scar itself is a deforming force against the toe. So I use web space incisions, and I might do the second and fourth web space to take the metatarsal heads out. Obviously, I would have done more surgery than this lady needed because she did well with an isolated fusion, which is excellent. You know, I think one of the hardest things that's not well, that we haven't done a good job on a solution for is when you have splaying between two toes and everything else is okay. You know, maybe you have a little bit of a bunion or something like that, but you're splaying. I tell patients that I am not good at actually correcting splaying. And even after surgery, some patients continue to have some splaying. I consider that somewhat of a cosmetic problem because I don't think there's a correlate for pain with that. If you did a wild osteotomy and shortened your bones and we're hoping that your toes would line back up again, you'll still have the splaying. People have tried to imbricate the collateral ligaments. They've tried little weave procedures to improve that alignment, and I don't think anyone's been very successful. So although you didn't ask exactly that question, I thought I would throw that out there.
Dr. Abhishek, shall we go to the next case?
Yes, sir. And one more. Judy ma'am, how long do you pin your toes for a rheumatoid reconstruction?
6 weeks. 6 weeks. I don't know what your postoperative protocol is. When I have a plate and a leg compression screw like your construct, I will keep the patient off weighted for 1 week in a cast, and then I'll let them walk right on it in a cast. For 2 additional weeks, I'll take out their stitches and then I'll put them in a boot and let them walk in that boot for another 3 weeks. So for 6 weeks, I've held on to their great toe fusion, and at that same time, their pins are in, so I can remove those pins at 6 weeks. It's right on the edge of infection time frame, so you do have to keep an eye on those pins because those pins can be vectors for infection. So if the toes get any more painful instead of less, or get red, or that I'm concerned at all, I just pull the pins.
Thank you. Shall we go to the next?
Yes, sir, please.
She's an 18-year-old girl, and she had a history of fall 1 year back, but that was not significant fall. It was just a trivial fall, but she recollects. And this is the X-ray. She had pain in midfoot area, and these are her lateral X-rays, and she was complaining of pain in the midfoot area. This is AP lateral, AP oblique and lateral views. She was complaining of pain in the midfoot area significantly, and this history of fall was not very significant. She said she twisted in the field while walking, so that may be or may not be contributing to this. This is how is her clinical picture. So she is right side, and we can see little forefoot adduction, little arch which is significant, navicular popping out dorsally, and laterally and plantarly it is absolutely sclerosed. Only medial part is probably looking better. So obviously we are dealing with AVN of the navicular, and which is quite painful. I was surprised that usually younger people in our country who are working in the field, they tolerate significant amount of pain, but this girl had very significant pain in the midfoot. So now any thoughts, ma'am, on salvage, because she's pretty young, 18-year girl.
Yeah, I personally, I would get look at the standing lateral, but I also would get a CT scan of this if there was an opportunity to. And that would allow me to better understand how much of the bone is problematic.
Sorry, it is too fast to appreciate.
No, it's okay.
I will just,
No, it's okay.
just show you again. So
what you can see here is that there's a, really there's a significant non-union segment where she had a fracture, and it looks as though that bone is somewhat sclerotic. It doesn't have a good blood supply to it anyway. Based on what I can see here and what the pattern is here, I would prepare this person for a tail navicular fusion and naviculo-medial cuneiform with a segmental bone graft from their hip. That's what I would do. And I would plate across this. I had a case just like this. Actually, the girl had it on both sides. And I did just that. I took her iliac crest and I used it as somewhat of a segmental bone graft because a portion of that bone was bad. I don't know if these fragments are all bad or if there's something that could be like a third is bad and 2/3 are good. If you thought you could have contact, then you could consider just using, medial malleolar bone graft or distal or proximal tibial bone graft as cancellous graft. But if you need a segmental bone graft, you could take her iliac crest. Those are the things I'm thinking about.
And so, ma'am, do you recommend to do MRI scan along with CT scan to see the vascularity?
I would. I personally would. Because I'd want to know which part of that bone was good and which wasn't, because it would impact where I get my bone graft from. So I didn't want to ask for too much.
So, ma'am, we did same thing what you said. We took dorsomedial approach intraoperatively. I did not do MRI scan, but I decided that intraop whatever was viable we kept. This was viable and has attachment of the tibialis posterior along with it. So, and it was anyway good bone. So whatever was sclerotic, hard, and non-bleeding, we took it out and distracted. We got the tricortical iliac crest graft. And when I measured it, suppose it was 1 centimeter. So we got 12 millimeter or 13 millimeter big graft, so that it was absolutely press fit. And the cortical part was kept dorsally. And we distracted and then punched it inside. It was so nicely fixed that we were even prepared for plate and all those things. But I ended up in doing only 1 screw, which I won't recommend, but it was so press fit here that I never thought that I will need a plate, but I won't give this as a take-home message. And this is how she went on to heal here. And arch is also there. In this view, it looks like it is some little bit adducted still, but she's doing quite good clinically.
That's fantastic.
So probably we are dealing with Mueller's-Weiss syndrome, which is avascular necrosis. And any more thoughts on this, ma'am?
No, you know, I think, you know, you made an intraoperative decision about that one medullary screw, but I personally would have bridge plated across, and only because I wouldn't have faith that that would happen. How long did you keep her non-weight bearing?
Almost 10 weeks, ma'am.
I did this. I kept mine longer than you usually do because it's a segmental bone graft and you have to heal both ends. And I kept mine non-weight bearing for nearly 3 months, and she also was 18 years old. So I think all of those, the young age helps us for sure.
Yeah.
And you know, the scary thing is I had to go for the other side after I got success on one. That was the scary part.
Yeah. Rajesh sir wants to say something.
So, ma'am, if while doing reconstruction, you have to sacrifice the navicular tuberosity, what would you do to tibialis posterior?
Yeah, you know, I would have used a biotenodesis screw for that and reattached it at the same time. I don't know if you sutured it into your repair or how you dealt with that small fragment of bone, but I probably would have attached it into the base of the medial cuneiform and held it there. I think there's a lot of different ways you could potentially do that. You could also, do some incorporation with your plate. You could fire a screw that went into that fragment if it was large enough. So I think there's a lot of different ways you could attack that, but I do think you have to worry about the stability of that.
Right. Dr. Abhishek, any
Judy ma'am, when you're fusing the talonavicular and the navicular cuneiform joint in this procedure, does tip post have any role still left for it?
Does the
tibialis posterior still have any role, because you are actually sacrificing the joint where it is designed to move that area, but you are already fusing the joint. So what if I cut the tip post and just leave it over there?
Yeah, I think that in an 18-year-old, I think that it does have some role in initiating heel rise and things like that. So I would feel compelled to reattach it. I understand what you're saying. You're locking it up at the talonavicular joint. So does the posterior tib tendon have any role? But I think at this young age, it probably acts to aid in heel rise for toe off and things like that. So I probably would make the extra effort to reattach it. If someone was, my age, I might not, but at 18, I'd be more hesitant to let it fly free.
I agree. And that's the real reason why I asked you, because in a young age, I think the attachment that come on the plantar side also has a role where you can actually act like, otherwise, I think sometimes it might just, with her longevity, it might just sag down, which we don't want the midfoot to sag longevity wise. Theoretical thought process from my end, but even I would at least suture it down or tag it down somewhere where it gums up in my midfoot region.
Mm-hmm. You know, some people would even say, well, with this degree of surgery, they even would lengthen their gastroc.
Yes.
Something to try and give yourself a mechanical advantage for that fusion to heal. Again, in an 18-year-old, I probably would not, but all those thoughts would go through my mind when I was seeing this patient.
Coming back to the gastroc lending, how many 4-foot surgeries do you do a gastroc? Because like the French surgeons do it a lot. Like, what is your thought process on that, ma'am?
Yeah, I am not a big gastroc lengthener for the forefoot. If I'm in the midfoot or the hindfoot, I've got much. It has a role. I don't always or never do it. I'm not a always or never person for those things. I think I'd reassess if they had tightening, and then whether or not it'd be beneficial to them. This is this case is a hindfoot case of midfoot hindfoot junctional, and it actually involved. We talked about the medial cuneiform navicular, but it's into the middle cuneiform joint too. Because of the navicular and stuff. And it probably, I think the good part of it was over at the lateral cuneiform where it still was the host bone. So you were actually fusing the medial and the middle cuneiform joints with that segmental bone graft.
Dr. Abhishek, shall we move on to the next case?
Yes, sir.
Which is hindfoot. We have 2 hindfoot cases and an Achilles. She is a 65-year lady.
Sampath, as we are running short of time, can we take the Achilles case, which would be of more interest to our audience?
Yes. How much time we have, sir?
We have now 8 minutes.
No, we have half an hour, sir. Let Sampath sir present the whole.
Half an hour?
Because it's 1.5 hours, no, sir?
Yeah, so okay.
So we started at 5:30.
Sorry, Sampath, go ahead.
Go ahead, sir.
So she is a 65-year lady, diabetic. She has diabetic neuropathy and such a gross deformity that she did not walk for almost 2 years. And these are her x-rays. Obviously, she had neuropathy. These are her x-rays were seen. Now, my biggest question was again to differentiate these x-rays when if they're only due to neuropathy or infection. That is one. And with this gross deformity, when she's not walking for 2 years, really what is happening inside? Is it only due to neuropathy or infection? How do we differentiate, ma'am?
Well, there's multiple ways to think about this, but my first thought is a common sense thought. If this was resorption due to infection, she would be sick, right? That degree of chronic infection and resorption is a lot. So I'd think about that. I'd ask about open wounds. If you don't have an open wound, it's unlikely that this is infection. Second of all, with the diabetes and things, sort of leads you down that road of neuropathic Charcot. And then, if she's lost her sensation, then that also supports that. That she doesn't have any pain. Infection's painful. If you're worried that she's diabetic and neuropathic and has infection, you can look at her blood levels of sed rate, CRP, white count. Those sorts of things will give you a guide. You could also aspirate this joint to see if anything would grow out, because it really should if it was going to, or bone biopsy it. But I think this is going to be run-of-the-mill Charcot arthropathy with significant talar loss, which is quite a challenging case. She has very little calcaneus left. How flexible is this thing? Does it reduce?
It is moving on medial side only. I cannot correct it towards lateral side. So this is only moving on medial side. Because of a lot of contraction here, she was not able to make it reduce on lateral side.
What's the old incision from?
Probably somebody has thought it to be infection and all those things just to drain out, but then they yielded just those typical bony grit, everything. So she I inherited patient like this after 2 years, and let me show you what I did, because we have similar two cases where you can give us some take-home messages. We decided to go for TTC fusion. As you said, there was a lot of bone loss, but our main aim was to get axial alignment correct. This is how we utilize transfibular approach and fibula for bone graft to build up the bone over here, a good axial alignment. And these were the intra-op pictures. Now this is post-op. We did not do anything to the talonavicular joint. We have reconstructed the TTC with a TTC fusion. This is her follow-up after 2 years. Everything has fused well. We did not do anything to the talonavicular joint. And she's an international patient. She's walking well. Although I always suggest my neuropathic feet that I can make your foot braceable. Please do not walk without brace, because we have corrected your deformity, but do not strain the implant, because still there is a possibility that she may again break our implants, but they don't listen. She has sent me again video where she's not using that brace which I gave her, because they are anyway painless. And she sent me this video almost 3 years after surgery, but she's not using the screw shoe which we gave her. So, any
well,
thought?
good for you. I have those exact examples, and I've lost the leg, and it's because you got the great alignment, but the bones never fused, or you had Charcot that occurred during your recovery, and then everything loosened, and the leg just went. So I am so happy for this lady because it turned out so well. But I think anyone who's a foot and ankle orthopedic surgeon has had a case like this where they've tried the same thing and it hasn't worked out. And I think preparing your patient that, in fact, you could lose the leg with these reconstructions is also a very healthy conversation to have with the person.
Yeah, ma'am, just to show you that what you said, let me present another case very quickly so that you can sum up very nicely. This is 70-year lady, diabetic. Some of my colleagues have done this fixation. X-ray looked good, but everything fell apart. Everything fell apart. No infection at all. Clinically, just it fell apart. Everything was good, but it fell apart. Then I went inside. I did TTC fusion. On the contrary, this time bone stock was very good, no infection. And 4 months later, this was clinical picture, very quiescent foot, but see the X-ray, everything fell apart. Everything fell apart. Again, I thought probably it's an infection, and but blood markers were good. Everything was good, but here this time we lost the leg. I mean, this was below knee. She landed up in below knee amputation. So my few questions to you, of course, to tell you the other markers. Here, first lady had good vascularity, and second lady, I always do the arterial Doppler. Here, it was neuropathy with vasculopathy. So my question to you is, clearly there was, if infection is an issue, then it is a different issue. But two questions: neuropathy with vasculopathy is one determinant, and second, the stage of disease itself. So can you guide us what stage of disease we should touch them? Because clearly even the fixation fell apart in this case when there was no infection. So did we touch the neuropathy in some active stage of disease?
You know what? I'll address the first thing, which is vascularity. First of all, people do not Charcot if they don't have good blood flow. So your person may have had some impaired blood flow, maybe calcifications or whatever, but the dysregulated blood flow of Charcot occurs in people who have adequate blood flow. If they have terrible blood flow, they never Charcot. So I'll say that first. Secondly, the staging wise, we all talk about maybe when the bone is in sort of stage 2. Stage 1 is fragmentation stage. And you could imagine that this woman who had an acute ankle fracture had an initial fixation and then fell apart there and then came to you, was probably, evolving stage 2, going towards stage 3, but probably hadn't really consolidated as much. Maybe you could say that. But you sort of want the bone, you want all the swelling to go away and all the warmth of a Charcot to begin to operate on it. But often we don't have that luxury, You couldn't leave this person like this for them to open their wounds or things like that. So I think the post-operative care is equally as important as the intraoperative care. And patients have to realize that they have to put their toes above their nose to decrease the swelling and no walking on this thing. But I'm not sure everyone does that for us. And that is part of the conversation you need to have. I almost scare people to death because I say, you walk on it, your leg will go. We'll lose the leg. You walk on it, we'll lose the leg. So I think those are all conversations, and you could do the very best job in the world, like I think you did actually, and lose the leg, because if any of those other factors that you don't have control over happen, then you're in trouble. Did you prepare your subtalar joints for these?
Yes, ma'am. Yes, I did.
There's some literature that says you do not have to prepare the subtalar joints, but my experience has been if you don't prepare them, they don't fuse, and then you have even more trouble. So I just thought I'd say that comment because I've heard it before.
Sampath, could you go back to your first case, post-operative image? Yeah. So you used a fibular plate.
Yes.
So you don't fix the fibula with one screw into tibia and one screw into talus or into calcaneus. You use the plate for fibula.
Yes, sir. I did same thing. That through plate, I used one screw in the calcaneum and one screw up holding that graft again.
Yeah, they
Abhishek, we cannot hear you. Pradeep, would you like to take over here? Pradeep, can you take over?
Yes. Can you hear me?
Yes, we can hear you clearly, but there is an echo.
Sorry, yeah. I had two devices working. Fine. Okay. Agnivesh, sorry, Agnivesh.
Yeah, I'm here.
Yeah, Agnivesh, can you run the video which I've sent you, because I have some issue with my laptop, so I don't want the video to be stopped. So I am running on two devices because my laptop was giving an issue. So if you can run the video from yours, I think would be good.
No problem.
And Malar both are here. So we will hear and we'll probably take some questions and we can answer them as we go along as well.
Sure. So I'll just start sharing the video.
Sure.
Okay. Just before I start, am I audible now, sir? Pradeep, can you hear me?
Yes, yes, I can hear you, Abhishek.
Okay.
Yes, Abhishek, can you take the questions from the
Yes. Any questions that we need to see? There are none on the chat. There are none on the YouTube. But these were difficult problems, especially with the neuropathy and the differentiation between. I think we have Pradeep, who does a lot of good work on Charcot. We have Sampath sir, everybody, Mallar. And I think it's a very pertinent question that comes to all of us nowadays, because it's something that I think diabetic is a pandemic that we are sitting on besides the one that we are facing now. I think they were difficult questions that patient poses us. I think it's important that we treat it appropriately. Any questions that Mallar sir or Pradeep sir wants to, like any comment that they want to give, especially about these questions, about these cases?
I think, can I go ahead?
Yes.
While I think Agnivesh is loading it up. So
yes,
regarding the first case which of diabetic neuropathy, which Sampath showed, see, what I do is I know those are very bad deformities, but they come with a lot of swelling initially because nobody's immobilized them. So every time that abnormal movement is happening, there is a lot of, effectively you can say a synovitis type, which as I call it as a Charcot. Okay, I'm just recording now. Yeah, if you just pause that, Agnivesh, 2 minutes. So what I do is I immobilize them. I put them in a cast, a nice molded cast. You have to make sure that the pressure points are all well padded. And you wait for some time, and you will suddenly see that in 2 weeks, 3 weeks, patient will come weekly, the plaster has become loose, At the same time, two things you are trying to achieve. One is, of course, the whole swelling is going down, the tissues are getting better, the tissue edema goes better. So when you're going for surgery, it's very helpful. Second thing, when you immobilize them, the body starts or the limb starts producing more bone. So if you have very less bone, you start getting more bone around it and you can play with that. So like in your if you have minimal bone or the talus and the distal tibia, you have decent amount of bone. And if you can carry on this for 1.5 months or something, you will find that a reasonable bone stock, where at least you can put your distal screw. So don't rush into things, try to fixing. Yes, ultimately you will have to do a hindfoot fusion or something, but buy some time by initially conservative treatment. That's what I would say.
I think that's a great suggestion. I think without wasting too much time, we are already 12:30. Yeah. So I think we have an hour more. I think Pradeep can go ahead and start the flatfoot session. Yeah.
Okay, I'm just recording now. Okay, sharing my screen. Can you see my screen?
Yes.
John, you okay? Comfortable?
Yes, I'm good.
Great. So what we'll have to do is probably, since we have only 33 minutes, I think, 32 minutes. So we'll just ramp up through the cases. So I'm just going to skip this case and come to this case. Jim, thank you so much for joining for the Master Shares program. It's one of the esteemed program of the Bombay Orthopedic Society. Thank you, Mallar, as well for taking the time out and being a part of the moderator of this session. Without much wasting time, so case number first we want to discuss is a 32-year-old chap, pain in the left ankle for a long period of time. So he remembers that it went on, but in the last 3 to 6 months, it's been quite bad. He's unable to do his activities of daily living, unable to stand for more than 10 minutes. And because of the foot, he started having issues with his knee and the back as well. His brother is a cardiac surgeon, and really he wanted something to be done for this gentleman. On examination, flexible deformity, too many toe signs positive from the back, unable to do a single heel. So he would start for first, and the second and probably third and fourth, he would really struggle it. 4-foot abduction, silver spot positive. This is what was clinically seen. John, over to John. What do you think, John? Anything else to add in this examination?
Since it's a young male and unilateral, I would look for something that is congenital or in some way.
Mm-hmm.
So the first question would be whether the posterior tibial tendon is ruptured or not, or is it just insufficient? And another thing would be to look for the obvious, which is the coalition.
Mm-hmm.
So John, how do you make out whether it is ruptured or just dysfunction on clinical examination? So how do you do that?
Well, the insufficiency is described as remaining of the healing valgus in the single or bilateral heel rise, with a testing which is so-so, I would say. It may be painful, but definitely the posterior tib is still there. I mean, it functions. Maybe it's weak on a, I would say, 5 to on a 5 on a 0 to a 4 on a 0 to 5 testing level, but it's there. So you don't know whether it's tendinitis or a small rupture or something which is regarded, I don't know, a spring ligament or something which is distal. So you need to know what's going on there.
So, as I said, this gentleman had more pain on one side, though he was almost like, if you see on the clinical picture, he was flat-footed effectively on both sides, but left was definitely severe than the right. So I would say not unilateral, but bilateral, but point taken, John. Would you like to see the x-rays or anything else in the examination? Have I missed something that you would like to really tell the other orthopedic surgeons to look for?
Where does the pain come from? Is it a medial pain? Is it lateral? Is it both? And is it?
Yeah, sorry, go on.
And is it from the tendon on the medial side, or is there a pain on the cestataculum tali? This helps.
Sure. So his pain was more on the inside, okay, more on the tibialis posterior tendon going right up to the navicular tuberosity. Also pain slightly on the outside as well, you know, around just below the lateral malleolus, around the sinus tarsi area, there as well. So both sides. Hello.
Yes. Go
yeah.
on.
Okay. So I'll just move on to the X-rays, weight-bearing X-rays for both sides, lateral standing.
This is congenital for sure, because you see the beak on the head of the kid. With this, you know that this is developmental.
Okay.
So you need to look.
So when you say congenital, you mean to say he may have a congenital flat foot, but it is not of correlation, correct?
Well, that you don't know.
Okay.
You know it's congenital, but this is it.
Okay. Now, it's interesting because this talar beaking I have seen in patients even at the age of 50 and 60, where the talar beaking has been there and we do not know the exact cause of it.
My understanding of it is that the beak is developmental, which means there was this deformity, or there was this this deformity during the growth of the foot.
Okay, okay. So anyway, these are the X-rays. So the same X-rays, we've done some measurements. Calcaneum pitch on the right and the left. So right was around 16 to 17 degrees, left is 10. The Meary's angle around left side is 20, right side is around 14 degrees if I'm not wrong. And the talar uncoverage was around 40%. and the AP tailor metatarsal angle, first angle is around 14 degrees. Now, does this help in any way in a treatment algorithm for patients in your book, John?
Yes, definitely. There is one thing missing, which is the hindfoot view.
Yes, I tried to search for it, but I just couldn't get it. So, but otherwise, yes, Salzman view, we get it, standing Salzman.
So, because the issue is whether or not, well, the first thing to address is whether or not the ankle is jeopardized.
Mm-hmm.
Is there a tilt of the talus? And where does the deformity, the principal deformity lies? Is it on the heel that you will have to address to protect the ankle? Or is it in the foot, which is the abduction, abduction? And here, it looks congenital. It seems mainly abducted. So first thing first, I know that I would have to perform some sort of bony procedure to realign the foot.
Mm-hmm.
That I know. What I don't know yet is the whether or not there is a coalition, whether or not how the posterior tibial tendon is, and how tight it is on the Achilles, not on the Achilles, but on the triceps and on the peroneus brevis.
Okay.
Since whenever there is a developmental foot, there is always a soft tissue part to it. I mean, the bony part is only the tip of the iceberg.
Okay. Okay. So I, for the sake of time and other things, I have not put any other, but MRI showed, so there was definitely no correlation on MRI. Okay. There was definitely the tib post was really stretched out. The spring ligament was stretched out as well on the MRI. And joint conditions were quite good. Would does that information help you, John?
Yes. So I would say that it's a congenital flat foot with some sort of injury of the spring ligament.
Mm-hmm.
So one need to address this injury, and in order for the spring ligament repair to work, then we have to address the bony deformity. So in that case, I would probably go with a strier lengthening of the peroneus brevis.
Mm-hmm.
I do it above the ankle, and more often than not, I would go for an opening wedge osteotomy of the calcaneus at the sinus tarsi, which is some sort of an procedure, but it's been described by Hinterman.
Mm-hmm.
So it's not a lengthening; it's more of an opening wedge osteotomy. You keep the medial cortex intact, and then you address the medial part of things, and to repair the spring ligament, which is usually stretched out from the navicular.
Yeah.
And so I repair this, and I suture both the capsule and the spring to the remaining part of the posterior tibial tendon. And when this was done, I check whether or not the pronosupination of the forefoot is balanced. If not, I would go for the cotton osteotomy.
Okay. Okay. So we discussed this MDCO in all patients, FDL transfer or not. Spring ligament, you already mentioned it. Lateral column, I think you have mentioned already. Probably do Hintermans more than Evans. And gastroc, I think we have mentioned it. So this is what I did. I did a MDCO, and I also do an Hintermans. So really go into the middle facet, opened it up, and then you can see how the coverage of the tailor head has come back normal. So this is what I did, MDCO plus transfer. The spring ligament, initially I used to use a stump of the tip post, but now I rely more on the internal brace. I think it just gives a better, because the tissue is so large, it just internal brace is better, I think. And lateral column lengthening and gastro. and that's a 1-year follow-up. Definitely he's much better. He still complains of slight back pain, and he's able to do a single leg. So, and he works for the Hare Krishna, Hare Rama, so he almost walks always barefoot. So that's one downside to this whole rehab program.
So you definitely were right to address the valgus heel,
yeah,
which I did not mention because I didn't have the hindfoot due.
Sure.
But definitely it had to be done. The FDL transfer would probably be performed if there is on these young patients, if there is a rupture, an obvious rupture of the posterior tib. If not, I do not do it in all cases.
Okay.
But it's and as you mentioned, I use the internal brace option.
I think it just gives you that solid feel on the medial side. I don't know. What do you think?
Yes, I definitely agree.
Great. Okay, I'm going to stop sharing and I'll hand it over to Malar for the next case.
Yeah. Shall I share the screen?
Yes, please.
No, but you have disabled, so you'll have to enable me.
Hold on. Make host. Okay, Malar, you should be doing it now. You should be able to do it.
Okay. Yeah. Are you able to see?
Yes, Malar.
Yes.
Okay. What's coming up? Yeah. So I think I'll skip this one. Okay, so there's another flat-foot 45, 47-year-old lady with a left-sided problem, and she has been like this for more than a couple of years, about 4 to 5 years. And this is the front view, and then this is her main complaint is on the left side. So this is the looking from behind, and you can see the classical heel valgus and the too many toes sign. And I tried to correct it. She had a supination, but correcting the heel valgus, the supination of the forefoot got corrected. And does this help, Jean? Anyway, testing for whether the forefoot supination gets corrected on correcting the heel valgus?
Yes, it means it's a hindfoot-driven flat foot.
Yeah. And so how does that change your does it change anything in your thinking process, in your management or something like that?
If we are able to correct the deformity with the hindfoot, with only addressing the hindfoot, more often than not, you end up doing a limited surgery to the hindfoot and doesn't require anything on the forefoot. And one thing I need to mention here is when you lengthen the peroneus brevis and you keep the peroneus longus, it gives you a little help, because whenever you lengthen the lateral column, it will tighten up the peroneus longus, which plantar flex the first ray, which helps.
So, before we move on to exercise, would you need anything else?
Whether or not, well, she looks like she ruptured her posterior tibial tendon, for one thing. She looks like she's heavy.
Very heavy.
And I would wonder whether or not, well, two things.
Yes.
First, whether or not the subtalar joint is painful. And
Yes.
second, is there pain or some sort of abnormality on the medial sole of the ankle? Because
yes,
she has curved she has bow legs and very, very valgus heel.
So, so this is the X-ray, the standing X-ray of the involved side. Would you like to just describe or analyze the way you analyze X-rays?
Well, she has an obvious equinus of the talus. She broke her Mary line at the Chopin joint level, and the Lisfranc looks pretty good though.
Yeah.
So I would like to see both dorsal plantar view and the ankle view.
So there's a dorsoplantar view.
Oh, this is weight bearing?
Yes.
Okay. Well, there is not much to say here.
Yeah.
Unless one says, well, it's a gross deformity.
And this is the ankle weight bearing.
Okay, so the talus starts to shift and to tilt. Well, to tilt more than to shift. There is a narrowing on the lateral side of the subtalar joint. Well, in this case, you end up between a hammer and a hard stone, because one option would be to fuse the subtalar joint. So as Hinterman proposed, you fuse the subtalar joint, you have something which is stable, you correct the talus over the calcaneus, and then you add up the FDF transfer. So that's one thing. But the tricky part is, doing so, you augment the lever of arm of the valgus. So it somehow increase the biomechanical share on the medial on the deltoid ligament. But because she's she's old, I would say, although I'm 52, so but I would probably go for the fusion instead of the MCO. But I would talk with the patient, saying, if we go to the MCO, there is less concern about the ankle, but there is more concern about some sort of persistent pain on the lateral part of the ankle, of the subtalar joint. And the other thing is, she has bow legs. So whether or not she's painful on her knees, whether or not you believe she may be having some sort of knee surgery soon, because if there is an alignment on the knee, probably will modify things on the ankle, and you'll be more comfortable with a conservative surgery such as a MCO than a fusion.
Yeah. So this is her involved knee, the same side knee.
Okay. And is it painful?
No, this is not painful. And this is the opposite knee.
So this one, is it it's painful?
It is painful. This is painful.
Okay, so one needs to start with that knee, because the ankle surgery will require non-weight bearing on the left-hand side. So I don't see her weight bearing on that knee. So this needs to be addressed first.
Yeah, but she was not ready for the knee replacement at this age.
Yes, but at least doing some sort of opening wedges to
So what is your thought process? Do you do the proximal problems first, because we many times face patients with knee and the ankle both, and it might be on the same side or on the opposite side. So what is your algorithm of treating problems having both at the ankle and at knee in general for foot and ankle cases?
Yes, I understand. I would probably rather go for the knee first, with some exceptions, such as flat feet with total knee arthroplasty already scheduled. In which case, I think to realign the ankle first, about the rear foot first, is probably better, because of the rehab. If it's been published, but whenever you keep the abduction of the foot, the rotational stability of the total knee is more difficult to obtain, both for the surgeon and for the rehab. So in this case, I would go, but again, it will depend whether it's a fusion or a conservative treatment of the foot and ankle.
Yeah. So
in this case, I would go for the right knee first, then the left foot, then the left knee.
Yeah. So she was not ready for the total knee as of now. She felt she was young for a total knee.
Yes.
So I discussed all the options, and as you told, I talked about reconstruction versus fusion. Yes. And me and her decided on doing this a double. Okay. The subtalar, yeah,
double.
Yeah, double. The subtalar and the talonavicular. So, so that is what we did. Only it looks okay with. I found her to be very lax at the ligament part, especially both the medial and the lateral, and found that the opposite ankle, the right, also had significant opening on lateral and medial stress, which was same on this side. So I don't know whether it is because of a generalized laxity, ligamentous hyperlaxity. She was having, because she had a gross deformity at the knee, on the opposite knee at 45, 47. Yeah. So maybe something in her collagen tissues. And if you can see in the post-op X-ray, you can see a tilting on the opposite as what we compared to saw it in the pre-op, where it was on the medial side. Now it's opening on the lateral side. So how do you explain, or what sort of take you will have from this?
I think I agree with you. She has some sort of general laxity because of both knees, because of her age, and because as you mentioned, as we clearly see here, what you get from the medial side, you get from the lateral side as well. So definitely the subtalar fusion was the way to go, because you need bony realignment if you cannot rely on the soft tissue things. And in this case, I discovered that more often than not, even though I would go for, I tell the patient, I realign the hind foot, the subtalar joint, and then I'll check the Chopard joint. If it's okay or so, because you're young and because there is some concern of laxity or something, then I will go for the FDL transfer.
Okay.
Because the subtalar joint, once you fixed it, you fix the rotation as well. It more often than not, it realigns the Chopard joint as well. and you keep this chopper helps sharing forces between the ankle and the forefoot. So it gives you a little more time.
Gene, what I have found is exactly, but especially as Malar has shown, these are short Indian women which are heavier. So in spite of just doing a subtalar and then doing that FDL and FDL transfer, the FDL just does not take enough load to really balance on the medial column. So I've had done couple of cases, but these people then suddenly start again tilting on the midfoot area on the medial column. So and
well, the thing is, if you do if you do the subtalar fusion plus the FDL transfer, you still need to address the pronosupination or make sure that there is only issue there. You mentioned that once you realign the hindfoot, you had no pronosupination issue. But if you were, then you definitely want to put down the first ray, so to realign the tripod.
Yeah, so that's why the slide for the alignment pre-operatively, wherein the supination got corrected with the hindfoot. So my thought process was not to touch the show part and the forefoot as of now because it got corrected. Would you have done anything else differently?
Probably not. I would have asked myself whether or not it was useful to fuse the talonavicular joint or not. And whenever you don't fuse it, you usually end up with more supination because the fusion of the talonavicular joint helps you bring down the navicular. So basically you pronate the forefoot. If not, you cannot rely on the FDL transfer to pronate the forefoot.
So that's what I was asking. That if you're doing your FDL, then probably the chance of doing a cottons would be probably higher.
Yes.
Yes.
Yeah, definitely.
Okay. Malar, can we move on? We just have like I'm not okay. I'm okay for time. It's just John's time.
Yeah. So
okay.
So I've stopped sharing screen.
Yeah.
Okay.
You need to make me an host again.
So how do I do that?
So if you go in participants, just go under my name and then say make me host.
You are already host. I have already made you host. You are already a host. Dr. Pradeep, you are already a host.
Gautam, this is the recording. So if we were doing that time.
Oh, okay.
It's only from the recording only. Don't worry.
Done.
Okay, fantastic. Thank you.
Done.
Yeah. So we covered that case. So next one. So 16-year-old girl, student by profession, pain in the ankle and the foot, swelling present, point tenderness present on the navicular tuberosity, tibialis posterior stain again, going up and down on single heel, was able to do it. Not an issue. This is a clinical picture. Okay, so pain on the right side on here. And if you zoom in, this is what the prominence is. Anything else you want to know? Means yes, she was not tight on the gastro. Rest everything was fine. John?
Well, the things are different from this part of the world because usually people complain about the shoe wear.
Mm-hmm.
So they come because this rubs on the middle side of the shoe. So the first thing we try to address is whether or not it's a conflict between the foot and the shoe, so you can adapt the shoe, or whether it's an intrinsic pain from the we call it os tibial externe, which is tibialis external bone. but in your case, probably she's okay.
Okay. So X-ray, weight-bearing X-rays. This is where she was quite painful, and here as well.
So it's a large one.
Sorry.
So it's a large one.
Yes, it's a large one. So
there is a classification in which you have small ones, very small ones, large ones, and large ones which are included in the navicular. So this one is a type 2.
Correct. So I've given that. That's a classification 1, 2, and 3. So she probably fits in the type 2. So John, what would you do?
I would try to understand where the pains come from. So I would ask for an MRI.
Okay. And
to see, is it the yes? What's going on there?
Okay. So I think I had to ask for an MRI, but I don't have it with me. But it just showed a large accessory navicular tibialis posterior tendon was fine. Spring ligament was fine as well. Joint looked very good. No evidence of any correlation.
Okay, so then in that case, I would do the classic Kidner procedure, which is excise the fragment and reattach the tib post.
Okay. So when you sorry, go on.
Because of the size of the fragment, which is big but not big enough. In some cases, you have a really non-union of that fragment to the navicular, which you see, and which is painful, and which has a spot on the MRI on the SPECT CT. In those cases, then you can try to fix the fragment. Basically, you address the non-union.
When you reattach the tibialis posterior, how do you reattach it? Do you put an anchor and you suture the tendon, or do you use like a swivel lock and push it into the main navicular?
I reattached it. I don't use the swivel lock.
Okay. Okay. Fine. And this is like very good success rate for kidneys. John?
Yes.
And the success rate, or is it like quite successful? Any issues with the surgery or the outcome?
Well, it depends what's going on. So that's why a diagnostic is important.
Okay.
I would say I usually tell my patients it's 80% success, 20% some sort of failure. So remaining pain, maybe something on the, because basically we are weakening the tib post somehow.
Yeah. Yeah.
So,
okay. So I'll tell you what I did. So opened it up. That's where your accessory navicular is. This is your accessory navicular. This is the tibialis posterior. Opened it up, cleaned it up, freshened the edges, put a little bit of bone graft, and I fixed it. Okay. I fixed it with a Herbert's or differential pitch screws, and along with it, I did a shift. I did a shift as well, a MDCO, slide shift. And as you said, with the tibialis posterior, because I wanted to detension the tibialis posterior a little bit, and also give a helping hand to the union. That's your immediate post-op X-ray. And this is 2 years follow-up. That is united. This is still in there. And she's much, much happier. No issues at all.
Perfect. That's perfect. The only thing we could have discussed, which we did not, but we could have, it's whether or not, what's best for that medial aspect of the Chopard joint. Is it to have the shift, or to have some sort of events of stereotomy? Because when you do the intermanor stereotomy, you shift inward, you rotate inward the forefoot, so it diminished the shearing forces on the medial side.
Yeah.
On the post-op X-ray.
Yes.
does the talus and the navicular does the talus look uncovered on the lateral side?
Hold on. This looks uncovered on the lateral side here.
Yeah.
Yes. Yeah.
So I don't think so. We haven't done anything on the lateral side, and that's what I was just going to see the pre-op X-ray. See, if you look at the pre-op also, she doesn't have any tailor head uncoverage. So John, if you do a lateral side opening,
No, I wouldn't do it in that case.
Oh, you wouldn't do it in this case.
No,
Okay.
no uncovering of the. It's well aligned on the lateral aspect of the show part.
And see, it is well aligned on the AP and on the lateral. And if you go back on the post-op lateral, so there is, if you see maybe it's the X-ray view or the talus is little bit dorsiflexed, and it is uncovered on the lateral side. So maybe the osteotomy, medial osteotomy, led to uncovering. I'm not sure.
I don't know.
Or is it the X-ray view?
It probably maybe the X-ray. I don't know. See, look at this here. Then even both are non-weight bearing X-ray. So that's my But an MDCO probably would not shift the talus on the lateral side, would it? John?
I don't know.
Okay. You want to present your name?
Those are not weight bearing.
No, these are not weight bearing X-rays. But here her prominence has gone, her pain has gone, and she is much happier.
Yeah, she looks good.
Pradeep?
Yes.
John's time is over.
Okay. John?
Yes.
Thank you so much. Means if you have a few minutes, you want to go, or you're really, really short of time?
Yes, I've got to go. Thank you for having me. Have a good meeting. And I hope to see you soon someday. Sooner than later.
That's fine.
Okay.
Thank you so much. It's been a great session, really, and we have learned a lot. And I am hoping, and I'm sure the orthopedic surgeons would also find this whole recording very beneficial for them. Do you have to say anything, Abhishek?
I think just thanks, John. Apologies for the delay for technical glitches, but it's always fun. I have a lot of concepts coming from France, so I've trained at with Pierre Baruch and all. So I think it's always pleasure to see you and meet you. So let's catch up soon sometime, maybe ESCA if it happens, or sometime soon I'll see you there.
I'd love to.
Thank you.
Thank you.
Thanks, Agrivesh, for the recording. Abhishek, Malar, any questions or anything, points to be put which we may have not discussed?
I think it was good, very good. I think John nicely explained how he uses the peroneus brevis or bony procedures as compared to soft tissue, which are very important and easily missed on on a routine flat foot surgery that we do. I think we still have a good 15 minutes to finish. I think Pradeep or Malar wants to show some additional cases. We can go ahead.
Malar, you want to show some case? And then
I'll have to pick that one out. Anyway, I'll try. You can, if you have, you can start. And if I
I'll also open my. Yes, I think I have it. That's fine. I can do one case. Rajiv sir is here, or Abhishek? Rajiv Shah sir is here.
He's not there, sir. Sorry, I was muted.
Will you and Malar can moderate?
Yes, sure.
Okay. I'll just share the screen. Can you see my screen?
Yes, sir.
Okay. So 15-year-old girl, pain in the right foot and the ankle, unable to walk for more than 10 to 15 minutes. On examination, a partially correctable flat foot. This is what she had basically. Pain in the right, this area. Okay. She had both sides, she was almost flat, but right worse than the left. Slight hindfoot valgus, not too bad. Anything else you want to know in the history or straight away X-rays? Abhishek and Malar. Hello.
How was she at the other joints?
Other joints were fine. So she was not hyperlax or anything. Baton scores was quite good. No laxity anywhere else.
Okay. And her subtalar motion was free.
Subtalar motion was slightly restricted, partially correctable flat foot.
Okay. Okay. So the images.
Images are these weight-bearing X-rays.
Okay.
You want to read through? Anybody, Abhishek or?
Was the right?
Yes.
Shallow, navicular, calcaneonavicular fusion, something like that over there.
Yes. So if you see this, that is what she had. So if you see, so calcaneonavicular fusions, usually they talk about this anteater appearance. She doesn't have that here. Okay, where your anterior beaking of the joint happens, or the anterior process of the calcaneum, you have this beaking. She didn't have that. But if you see here how vertical the talus is compared to the other side, even the other side, the Meares line is broken, but the right side more worse than the left. And here also, see on the left side, she's okay on the calcaneonavicular, but right, there is definitely like a fibrous coalition present. And this is typical at this age, around 14, between girls 12 to 14, boys 15 to 17 or 14 to 16, they become more painful. Okay, anything else you want to add? So how do you manage them, Malar? Or any other investigations would you ask?
Yeah, I usually do both the CT and the MRI.
Okay.
And the idea of that is sometimes you can have an associated other correlation. So you just if you are on the suppose on the tallow calcaneal correlation, if you have it, and that can be a fibrous one. So you don't want to miss the other correlation in the foot. And if it is a bony one, then obviously you just want to see how big the issue is.
Okay. So we got a CT done. Here you can clearly see it's a calcaneonavicular fibrous coalition. There is still a little bit of tissue there. There is not a complete bony block. And even here, axial, you can clearly see here. I didn't get an MRI done. I thought the MRI probably may not add any more information to my CT. That's what.
Yeah. So the last image on this, I don't know whether I can use the pointer, but the last image on the talus, on the sustentacular talar part. So that is the area which interests on the last image. Yeah, that's the area. Sometimes you can have an associate. So I burned my fingers.
Sure.
One case. So patient had a persistent problem, and then she had a double correlation.
Okay. Point taken. But would not that be picked up on CT only, Malar?
Yeah. So sometimes if you have a fibrous sort of a tissue going around, not much as seen in this one, then you can only pick up on the MR.
Sure. Okay. So CT and MR, or what do you call as a combi scan. So invariably, if I, especially my flat foot cases also now, and this also has point taken, send the patient for a combi scan. So what happens is the cost also becomes reduced, and you get both an MR and a CT instead of patients going doubly separately. So how would you plan this? What would you do, Malar?
I would go in for an excision at this age with an understanding that she might not be fully asymptomatic, with an understanding of that, and put in a local muscle graft over there.
Okay.
I've put in a proline mesh once. I don't know how the patient was.
Okay.
never returned back. So either he's totally asymptomatic or he has sought the opinion of somebody else.
Yeah. So definitely, so options, leave it alone, only exercise the correlation. Interpose, I think you mentioned interpose, you probably use a local muscle flap or use a puruline or anything else. There in the literature, people say about the fat graft as well, you can do it. And abroad, you get a allograft a matrix as well, you can use it. And the key thing, I think, with John now is what do you do with the peroneal tendons? Do you do a tenotomy or do you do a you lengthen them or what else or just leave them alone? So these are all the questions which need to be, I think, asked before you go ahead with the surgeries. Anything else you want to add, Abhishek?
Abhishek is muted. Abhishek, you have to unmute yourself.
Sorry, sir.
You have to
You want
unmute.
to add anything else, Abhishek, into this?
No, I think I would always get an MRI scan because it also gets me idea about the cartilage status of this patient. Sometimes, as Malhar sir said, even I have been stumped couple of times where on CT I have done a excision, but the patient always persisted to have pain because the cartilage was already 1/3 worn out.
Okay.
So for them that was it.
Sure. Okay. And how would you approach this, Malar, in terms of the incision and the approach?
So I would take it the routine lateral approach, and then go into the anterior part and mark my bony points with a KY on both sides, and then do an end block excision. So on the C-arm, I have to be very sure that I'm at the exact point where the correlation is. And the good part in her is it has a good bony visualization on the X-ray. So I think it should not be extremely difficult.
Okay, fine, fantastic. So just go through what I did. Exercise enough bone so we can get mobility in the subtalar joint. So just pause that for a minute. So the incision is what they call as a oleus. So instead of the sinus tarsi going like this, probably a curvy linear incision. So you can go to the calcaneal navicular joint is probably what is described here. Open it up. You will always find a branch of the superficial peroneal. You need to identify and protect it. Once you have done that, you then probably are straight into your coalition. Once you go into the coalition there, you can see clearly the whole coalition is there. And what you can do is put a K-wire, as Dr. Malar has already mentioned, identify that you are really into the coalition. So you can find the fibrous tissue, put your either K-wire or a needle and make sure you are there in that space. Once done that, you need to take a nice trapezoidal or a big trapezoidal mass chunk out of the both the calcaneal and navicular. Make sure you have excised it sufficiently. This is what we excised it. And once that is done, so once I did that, the lateral side was quite tight. So did a peroneus brevis tenotomy and do a tenodesis of the proximal peroneus brevis tendon to the longus. Okay, so once that is out, you can clearly find that the joint has then become very supple. Okay, there you can see that once that was done, you can see this is the gap which is left. That's your talus, that's your anterior process of the calcaneum, and this inside is the navicular. I can literally put my finger in there. So a very good excision which has been confirmed on the C-arm as well. And now if you see the flat foot which was fixed now is completely mobile. That has become mobile. And from a rigid, it has become a flexible. So once that was done, then you can take the extensor, EDB, extensor digitorum brevis, take sutures through it, go through the space which has been created, come on the medial side, and then tie it on the medial side. Okay, so do an interposition with the EDB. That's your post-op image. And this is just a diagrammatic representation. What you do, you excise this, take the EDB, pass the EDB into the gap, and then come through the medial side and you can come out. Malar, you are ready with your case. Do you have time or anything else you want to add? Abhishek?
Perfect.
I think perfect. I think the counseling is important, and as you correctly stated, and Mallar sir correctly stated that not promising them the moon, because sometimes pain always comes back for these patients. Gautam sir, please let us know when should we stop. Accordingly, we shall stop, sir.
Hello.
Yeah, we can hear you, Mallar.
Yeah, so this is a rheumatoid patient with pain and difficulty in walking. And this is how she presented with problems in her knee and her opposite side knee and her ankle on the right side. If you can see the x-rays, I hope you are. She has a very bad knee, and this is the foot. And so now we are it's totally deformed with the talus almost touching the ground. And if you can see how she's been like this since more than a couple of years, and significant shortening on the lateral aspect of the foot. And this is the weight bearing x-ray. So if you can see, it's just even the midfoot is probably touching the ground, and the talus is totally out of the navicular. The head is pointing medially. So I think, and if you can see, the anterior process of talus has the calcaneum has also shortened on the lateral side. So how would you now go about this, Pradeep?
Yeah. So how old is she, Mallar?
About 60.
60. Yeah. And florid rheumatoid or well controlled now?
Controlled. So it's not. She's not very active. She was on methotrexate, but she was controlled with no flare-ups and on regular medication.
So I think the key thing is, and she's painful in the knee, or she's okay with the knee?
She is painful in the knee with. She wants a knee replacement, but the financial issues stop her from doing that.
Okay. See, my thing is, I think for her hind foot and the foot, I think she is planning for, or she is going to go into a triple arthrodesis or a double arthrodesis. My only always worry with these kind of patients is once you do your foot and then they go for a knee, and the knee surgeon then align the knee, what is going to happen to your arthrodesis? That is always my worry.
Yeah, so the only good part was the knee and the ankle were on the different sides. So so that's the saving point for me.
Correct. And second point, which I think John has already pointed out, when she's on the right side, she's going to be a non-weight bearing for say 6 to 8 weeks. How is going to be her mobility when the other side severe deformity of the knee? How is she going to mobilize? Is she going to be almost bed bound or at least wheelchair bound? That is that needs proper. I am not saying it's contraindicated, but I think that needs proper counseling with the patient and the family members. As long as we do a counseling session is proper, patient is aware of what she is up for it, I think she will need, I would do a double arthrodesis case. And with that kind of deformity, always skin and soft tissue is an issue on the lateral side. So another option would be to do a medial side, you can do a double arthrodesis.
Yeah, so that's exactly, I discussed with the patients that somebody is going to make her wheelchair bound and take care for about 6 to 8 weeks. So so this is what I did for the lateral is doing the as John discussed that day. I did a peroneal tenotomy of the brevis to just remove the deforming forces on the lateral side and let me shift the extreme amount of heel valgus. And then went on the medial side, and if you can see, the talar head is already out from the navicular socket, and the posterior tib is totally degenerated. And so as you rightly said, did a medial double, removed the posterior tib, and you can put in the hinterman and did a triple arthrodesis Is my voice audible?
Just
Yes.
breathing. Yeah.
Yeah. So did a triple arthrodesis of the subtalar and the talonavicular, and passed a screw on the calcaneal cuboid joint. So this is, sorry for the poor X-ray, but this is what was done.
So Mala, did you open on the lateral side for the calcaneal cuboid?
Yes. So I did everything on the medial side first.
Mm-hmm.
And then I had that thing, a tenotomy done. So then by that time, it took about 2 hours to do it on the medial side. And so after 2 hours, I again went on the lateral side and then did the calcaneal cuboid.
Sure.
So
Okay.
so
Probably I asked you. Sorry, go on. Sorry, Mala.
Yeah. So I didn't want to do it in the first stage on the lateral side, because it feels tempting that once you're on the lateral side doing the peroneal work, so why don't I complete the thing? So, but I wanted the lateral thing to stretch it out over a period of time and then do the calcaneal cuboid.
Okay. So you remember I was discussing this with you earlier as well. And when you do a medial double, and especially with that kind of deformity which you swing it out, do you really need to take a medial wedge, a large wedge on the medial side to get that talus, to get that calcaneum back under the talus?
No, not really. The good thing about these rheumatoid patients is their cartilage is very soft, and to manipulate, I find them easier. So I didn't have to do a large wedge to remove or to correct the deformity. It is just it's painstakingly to clear all the cartilage and gradually distract with the lamina spreader and the hinterman. And I find the putting the lamina spreader in the sinus tarsi area helps to correct the deformation at the subtalar joint.
Any tips on for people who may have not seen or plan to do on the medial side? Any tips how to go about and how to protect your deltoid?
I think the helps to correct talus, because the talus is usually quite dislocated from the navicular. So you need a very less space proximally. So your more work is on the distal navicular part, and you might have to sometimes use an osteotome and remove some part of navicular to exactly have that articular cartilage in front of you, because sometimes the osteophyte on the navicular is quite large, and sometimes you have, because you now the posterior tibia is gone, so you sometimes have to cut the navicular to have the exact cartilage over there.
Okay. And what about the posterior facet of the subtalar joint? Able to reach it easily?
Yes, yeah, that is not a problem.
Okay, fine. Great. No, great cases. Do we have more time, Abhishek and Gautam, or?
I think it has been a wonderful program today. I think just simply as a spine surgeon listening to ankle foot problems, it has been an eye opener, learning a lot from all of you. I would like to thank Dr. Abhishek Kini and Dr. Rajiv Shah for convening, coordinating, and moderating this fantastic program. I'm sure everybody has gained a lot, and on behalf of Bombay Orthopedic Society, I thank them. I would like to also take this opportunity to thank all the faculty, Dr. Pradeep Munot, Dr. Malaj Dave, and Dr. Sampath Dumre Patil, for being with us on a Sunday morning and sharing their knowledge, their expertise, and experiences with us. And I'm sure all of you have enjoyed the program. And if you wish to again have a look at the program will be available on our YouTube channel from next week onwards. And we would be happy for you to have a look at that. Thank you, everybody. And with this, I close the program and wish you a good day.
Thank you.
Thank you.
Bye-bye.
Thank you, sir.
Bye-bye.
Gautam.